here, you're happy with the minutes, and thank you very much, and we'll take them in that case as agreed. Happy? Yep, good, excellent. Question time. Haven't received any questions from the public, so we'll move on to item 3, which is questions asked by members. I have received a couple of questions from Councillor Ramsey Ross relating to Bradgate unit and capital expenditure. Councillor Ross has been provided with an answer collected from our NHS colleagues, and those answers have been published on the Canning Council website as part of this minute pack. However, Councillor Ross, if you wish to ask any supplementary questions, by all means do. If we can't provide any direct answers at this meeting, then obviously we'll make sure, Ewan will make sure that those questions are directed back through the system. But over to you, Councillor Ross.
No, thank you, Chair, for that. I'm happy with the answer, and I will take up the offer of a meeting at a later date. Thank you.
Brilliant. Thank you very much, Councillor Ross. Okay, so in which case we go on to item 4, urgent items. None have been notified at this time. Item 5, declarations of interest. Does anyone have any declarations of interest? Ross.
Thank you, Chair. It's just for the item of dentistry on the agenda. I do work as an NHS dentist, but not in Leicester, Leicestershire or Rutland.
That's great. Okay.
A general one, son and daughter work in the NHS.
Thank you very much, Betty. Any other links to NHS in any form at all? Brenda?
Thank you. Daughter works at the NHS.
Nobody else? Okay, good. Thank you very much. Right, so we're now on to item 6, declarations of party whip. I'm assuming there are no declarations to be made, but I'm looking across the room just in case. Nope. Okay, thank you very much. So presentation of petitions, item 7. We haven't had any petitions received. So now on to the main 3 items of the agenda. Item 8, which is the update on GP practice service improvements. Mayor, thank you very much for joining us. If you'd like to introduce your whole team to everyone around the room, that would be great. And then, as I said, we'll take the paper as read, which is fantastic. It's good detailed paper. But if you want to take a short period of time just to raise any particular items that you think you would like to sort of bring to our attention within the paper, that would be great. Otherwise, we'll then go to questions. So over to you.
Thank you very much, Chair, and thank you for having us here. So if I just pass on to Mayor Patel, Head of Transformation, and I cover primary care. So I'll pass on to Yaz to introduce herself.
Hi, I'm Yasmin Zidiot, Deputy Chief Operating Officer for the ICB.
I'm Dr. Sulakshmi Ninani, the Deputy Chief Medical Officer for LLR ICB.
Thank you. Thank you for notifying that the paper, I will take the paper as read. Couple of points I would really like to draw your attention to is you'll note that in terms of the paper talks about what work we have done across LLR in recovery of primary care access last year, some of the aspiration around what we want to do this year, and how does that impact on our experience or in our people, our community, and what they experience within the primary care arena. So few points to draw out is the number of appointments that we've delivered last year. What you'd probably note from on the page.
LLR Joint Health Scrutiny Committee meeting to observe.
Sorry, I think online somebody has got their microphone unmuted. I think it might be Jacob. Okay, thank you. Sorry, apologies. Okay, please, Mayor.
That's fine, no problem. On page 14 of your pack, what you will note in the table about in point 12 is around the delivery of additional 7.2% appointments. That equates to around 500,000 appointments in general practices. Now that's attributed to the work that we've done around workforce retention, enabling practices, PCNs, to understand the demand capacity. Some of what you will also know throughout the paper is the work we've done in modernising the general practice. And what does that mean? The whole modernisation concept of enabling them to implement cloud-based telephony, different way of enabling access for patients where they can, of course, and making adjustments, arrangement for that where the others can't, because of the capacity that's kind of frees up in terms of different ways of accessing appointments. What you'll also know is some of the self-referral pathways and in terms of what we have enabled from the system perspective, but there are lots of other non-mandated pathways that we've done as well, which is not noted. For example, crisis response services for friends and sort of family and around CVIP, mental health triage services as well, etc. There's quite a lot of services that have had self-referral pathway developed, which is not nationally mandated, but we believe is the right thing to do for our people, our community, and we're doing that. In terms of Pharmacy First, what you'll note is that's been we've launched that in January this year. Since then, we've had some fantastic feedback. A little bit sort of a teething problem in terms of the IT, as you would expect. Nothing that's being sorted, but on the whole, the feedback we're getting from our people, our community, that it's good. It's a good thing. It will take time, I think, to embed new ways of working. I think obviously our people, our community expects to be seen by general practices, but these services that are provided by community pharmacies, will make a difference in enabling the capacity for primary care general practices to be able to see patients with more complex care, those with long-term conditions, because of the other minor illnesses, if you will, are being seen by general practices. So the initial feedback, the number that's noted in the paper, it's fairly good. In terms of the one of the other key implementation we did last year was capacity access improvement plans that were sort of a national initiative, and how we kind of locally implemented it. Just to sort of note that for LLR, I think we were a bit of an exemplar in terms of, and a bit of a trailblazer as well in terms of how we implemented the whole capacity access improvement plan around the 30% of the payment that we enabled all the PCNs to access. This was around their patient experience and what are they doing about it, making sure that their recording of the appointment is accurate, so that we're able to do the analysis more meaningfully, as well as the nationally as well, in terms of the GPAD data people might have heard, and how we can use that, as well as the excuse me, implementing the friends and family test more meaningfully. So what you what we note is that in the March last year, we had over 21,000 friends and family reported, in comparison to not so much the year before. So great in terms, this is how we, so this is a step-by-step cultural changing that we are implementing in general practices, where majority of the work that they do, for example, this mainly around tackling the 8 AM rush and what we're doing about it, has been a bit of a custom and practice since 2004, since the GMS contracts were introduced. So changing culture, changing in which way they operate, changing in which way our people, our communities and patients access the service. It's happening in a bit of a stepped way, phased way, to making sure that no one is kind of left behind. I'd take that, if that's okay. I'm happy to take any questions. Thank you.
Great, thank you very much. Okay, I'm seeing a couple of hands going up already. Can I just ask a quick question to start off with? So it's a really good paper, and it's great to see a lot of the detail that's in there, particularly I think on a lot of the data in relation to access and take up of certain services. I think in truth it's as always, because it's covering such a broad area, it's a bit of a mixed bag in the sense that there's clearly a huge amount of movement, and I think that's to huge credit to those involved. But in truth, as in many areas with Leicestershire, we in certain key areas we sort of lag behind, both regionally but also nationally. Sometimes in access points and and some of the sort of performance figures. And I think probably from all NHS colleagues in the county area, I think everyone understands that, but also, you know, the momentum hopefully means that we're actually heading in the right direction. At what point do you actually see some of these figures as being, you know, finally we're actually ahead of the region, or we're ahead nationally on some of them? I mean, obviously we have certain areas where we stand out already, but actually in general terms, you know, particularly from access to GPs and the primary healthcare, you know, at what point do you actually think we're finally going to surge ahead of those other areas in the region?
Thank you, Chair. We've got a great opportunity this year for 24-25 in, again, doing the second phase of the recovery to access to primary care. There is a lot of sort of emphasis around sort of implementing an initiative that talks around how we can enable general practices and primary care networks to have the capacity to be able to manage patient demand. So there is a lot of work going on around recruitment, retention, workforce, sort of, you know, digital enablement of access, whilst not forgetting those who are not able to access through digital means, as well as sort of ensuring that the training and development is embedded within the culture in terms of how we enable sort of, you know, the development of our practices and their staff. So there's some key pieces of work that are going on this year, and I'd like to come back, of course, by the end of next year and be able to sort of demonstrate how we have done and what has that meant for our people, our communities, and in terms of the access. Anything to add?
Thank you very much.
Yeah, some of our key successes from this year that actually other areas have come to us to ask us, well, how have you done that, particularly around how we commission the services as well. That has made quite a big difference in terms of making sure that we have got local services like phlebotomy, for example, so blood services in primary care general practice. We've done a huge amount of work last year to get that to a position where we've got equity of access across all practices. We had variation in services. We weren't quite there. We've moved that forward. And actually now we've got other areas saying, well, how have you done that and what have you done? And a lot of that is about listening to our patients and our public. We're also listening to our general practice colleagues as well. They've had a tough few years. Trying to get things back post-COVID has been difficult, particularly around retaining staff as well, which has been particularly challenging during a very challenging time. So those are the things where we've moved forwards, and we would like to move forwards further. I think some of the other areas is about that engagement. I think one of the things we know for the last few years is patient engagement in things like friends and family tests have not been great. We've really worked on that. What we see is some really good feedback now coming through that. It's not always pleasant, but that's the right thing, because what we want to hear is the real stories. So we can work on that and move that forwards and take our practices on that journey around how they empower their patients to engage more with their practice on those things, so they have the opportunity to talk about their experiences, and that practices are able to then respond to those experiences in a meaningful way. And I want us to be coming back here next year to say, okay, we had that feedback. This is now the benchmark we're working to, and this is where we want to move forward to, and really move that forward. And those are some of our ambitions in terms of from a general practice primary care perspective.
And from the capacity and access work that we did last year, my colleague Sue is on the call today, who sort of, you know, supported with the other half of the paper, where you will note around the key pieces of work we did locally. Again, that's been a benchmark across the national as well as the East Midlands, around how we have gone out and supported practices and PCNs to enable this feedback, the patient experience feedback, and how we can then use that to support them delivering care through using population health management, health inequalities, and how they are kind of designing their services. So my colleague Sue is also on the call, who can sort of go through around the patient experience and some of the key pieces of work we plan to do this year.
Thank you very much. So one of the things which you mentioned that, some of the practices you will see that good way of working and how do we actually work with those practices. So what we are trying to do is actually getting that intelligence, obviously from the patient survey, but we have a quality dashboard as well. So it's about triangulating all the information we have, work through our quality teams to ensure that we can have that focused attention with those practices and PCNs and see what, how we can best support them to get where we want to get. So that's the work which is in progress. I think, some of the areas like you mentioned in terms of how we are nationally working and how would we reach. So we are good in some, some of the data which shows that we are good in some terms of face-to-face appointments compared to national figures. Pharmacy first, so we are doing really well regionally and nationally on those pharmacy first. One of the other areas which we have mentioned in the paper is the bureaucracy work which we have been leading on within our system. And we had the national teams visit us, and they were really commending on the work which we have done on the interface between primary and secondary care, because we know there was a lot of workload which we are thinking which comes to primary care which should be managed within secondary care. So we have actually worked very well along those principles through our transferring care safely, where we have got senior leaders across the system and working with them to manage any of those interface issues. And that's work in progress, but really getting good momentum on that one. Thank you.
Thank you very much. Okay, so I saw Betty's hand up, I saw Stephen's hand up, Janet as well, and then Ramsey. Who else have we got? Sorry, Zuffa. Sorry, hello there. Right, let's take those first. So Betty, you're first.
Thank you very much, Chair. It's really about the use of pharmacy, the community pharmacies. I personally do use mine, but I just wonder how much publicity is given out there to the public in terms of what pharmacies can do in terms of advising people who need help, whether or not there is something that your organisation can do to highlight. You could go to your pharmacy, you don't necessarily have to go to your doctor depending on the issues. So it really is one of people recognising what the pharmacies can do on their behalf. Thank you, Chair.
Thank you. Can always do more. We absolutely can do more. We've done a lot of campaign. There's been a campaign when the first Pharmacy First was launched in January. I think through our own social media platforms, as well as our general practices PCN, local pharmaceutical committee has also been in partnership in making sure that people and communities are aware of the services, and also part of our empowering patients to be able to access and have the confidence in community pharmacies to receive the services. But we can absolutely do more, and during the course of this year, we probably will do a re-campaign of that. Thank you.
Right, I think Stephen.
I'd like to know more about the actual impact of the self-referral pathways on patient access. What are the waiting times for patients who self-referred, and how has that changed over time, and particularly from when you started the house self-referral system? Because I understand some of the waiting times are very long, and does that mean that some people are not following up because the waiting times are long? So what is also the numbers of appointments before and after self-referral started? If you might not have that information, we can get it for us, please.
We don't have that information to hand, but certainly we can go away and work with those providers as well, who provide those pathways, and obviously work with our teams to get that data. So we'll work through that and share that back with you, and to share back with yourselves.
Thank you, and Ewan will be able to distribute the information when it comes through to the whole committee. Thank you very much, Stephen. Oh, sorry, yes.
Sorry, just coming back on that one. So yes, we can get the details of the information, but I work as a GP as well. And when we have referred patients, we have not had any specific issues, patients coming back to say, well, we didn't get an appointment. So we have not heard of any specific issues within my practice, but I'm not saying it couldn't be elsewhere. So we can pick that up and we can look at the numbers. But as such, personally, from my practice, we've not had the specific feedback. But yes, happy to take it back and look more detailed into it. Thank you.
Okay, next question we've got is from Janet.
Thank you, Chair. Yeah, I see in bullet points 35 and 52, and you've also mentioned it, this sort of growing importance or emphasis on transferring care safely. Healthwatch was actually invited to join Transferring Care Safely, and we did go along to several meetings. However, we were told absolutely categorically that this was a clinician to clinician referral. Patient experiences are not to be reported to Transferring Care Safely. It is not the right channel. So we dropped out because, you know, our main role is representing the patient voice. As you're putting more and more emphasis on Transferring Care Safely, don't you think that the patient voice should be included and not just the clinician to clinician referrals?
So thank you very much for raising that. Obviously, I've just come into the Transferring Care. I've just started chairing the meeting recently. But yes, I totally agree with you. Obviously, patient experience, what we do want, any of the things which we are delivering, we deliver for the patients and get that good patient experience. So happy to take that back. And obviously, it's a good time that you've raised this because we actually just had a meeting yesterday where we're looking at our terms of reference. So it will be really important for us to look into that and then feedback and look, and I can have those conversations with you. But really good point, and thank you for raising it.
Great timing. Thank you.
Great timing.
Okay. Next question, we have Ramsey in that case.
Thank you, Chair. I wonder if you could say a little bit more about the capacity in respect of Pharmacy First. And also, I have had a couple of comments from constituents about prescribing and the limits, and they've actually ended up having to go back to their doctor to get the prescribing addressed. And just, I was wondering what developments were proposed there. And then I'd just like you to comment on page 21, GP online services, and when these are resolved. I was wondering whether, given what you say in the report about the ease of use of the GP website, whether it might be better to focus on one or two areas to improve familiarity, to improve the rate of take up, because I think it's absolutely the right direction, but it's just how is this going to be accelerated? Thank you.
I can take the GP website question if that's okay. Thank you so much for that question, and very timely. Well, since last 2 months, we have been working with every single GP practice, 126 of them, to improve their practice website. So one of our local initiative has been to ensure that the interface through practice website or a PCN website for our people or our community is standardized and is in line with what the national expectations are, as well as what some of our local expectations around accessible standards and user friendliness, and how people, when they're accessing services, how easy it is for them to sort of, you know, navigate through the website and to be able to get what they need. So some really key pieces of work that's currently going on with every single practice, and we just had the webinar last week and all of our practices are attending. So there's a great piece of work in place, and I think we'd love to be able to come and talk about this at the end of the year in terms of how that has meant for patient journey through the practice website. So if that's okay, we're happy to sort of come back on that and later on in the year.
Thank you.
Sure. Sorry, I'll just take the question on the prescribing thing. So what we are doing is, obviously Pharmacy First went live only in January. So this is the early days. We're sort of looking at any issues which are being picked up by any pharmacies where they are struggling with the prescribing, or there's any learning need, and there's some local training being organized to support with those those pharmacies. So we are looking more into detail with that one. And we've also asked pharmacies to highlight to us where they feel that learning need is there and how we can arrange that local training and support which we can do within. So while that wider training is available nationally, but what can we do locally within LLR to support with that training and development, and any other issues which are flagging through the start of the Pharmacy First.
Ramsey, do you want to come back?
Thank you. No, the only other point was capacity. Do you actually think the capacity in the Pharmacy First will actually increase the take up, I suppose.
Yes. So if we look at the appointments and what has been taken up over the last few months, we have seen that in April there's been a rise of up to 14,000 consultations. So we can clearly see that steady rise. And regionally, we're one of the highest uptakes in one of those CPCS and the pharmacy first. So it's now more about specific areas. If we are finding any specific issues, whether it's with your blood pressure, whether it's with the oral contraceptive, what training and work needs to be done to be able to support more of those taking place. But it's more about how the pharmacies work closely with the PCNs, identify where the issues are, work together more collaboratively to support with that increased uptake, because that's where it works, is that relationships and working more collaboratively. And that's what we are building on with our community pharmacy leads.
Thank you very much. I have to say the Pharmacy First initiative actually is genuinely quite exciting, because I know plenty of pharmacists who are, you know, sort of biting at the bit to do what their professional training allows them to do. Obviously, 99% take up is incredibly impressive, but the 1%. Well, I mean, we must be just talking about one practice or two practices. I mean, is there an issue, or is it just a process?
Yeah, so I think the issue is we first had only the minor illness elements of it, and then we started with the pharmacy first. And the way the contracts are, they have to take the whole package together. So some pharmacies might have felt that they need more training and development to be able to then sign up for this, because they're supposed to provide the whole package of care. So it's about that. How do we work with those things? And if there is any training and learning, need to support them with that to then be able to then sign up for the whole package of care which they can provide.
Trevor.
Thank you, Chairman. On the same theme, obviously then what has come up out of your replies is the fact that there is a training issue need, and there's possibly then a recruitment and a retention issue within that package, which the pharmacists have to manage. How do you see that working out in the long run?
So this is where the close working with the LPC, the local pharmaceutical collaborative, is really important. So working with them, working with local universities, and working with local community pharmacies as well. We have a community pharmacy clinical lead who has been in post since 1.5 years, and their role is really around that professional leadership and support back to community pharmacies, and working very closely with local community pharmacists, but also the LPC, and also with our universities around that, you know, the training and development, but also around the workforce development as well. As you can imagine, there's a huge workforce development that is required in terms of this, and that's why it's 99% and not 100%. To be fair, you know, we were already at 95% sign up when we launched in January. So that just shows and demonstrates the work that we did using our clinical lead and using that professional leadership process to get our, you know, such a big majority of our community pharmacies ready for Pharmacy First. We've got still a huge amount of work to do. This is the first year of its launch, and there's some development work to do as well. There's development work to do with general practice as well, in terms of Pharmacy First, and how both community pharmacies and general practice work together to provide that more holistic primary care offer. And that's kind of the development and transformation work that we are focusing on. So leading on that from an ICB perspective, but very much working locally with our community pharmacy networks, but also working with the local universities as well.
That's great. Thank you very much. Right. Okay. So I've got a couple more questions. I think Brenda, you had your hand up, and then I think Zufar is after that. So do you want to go first in that case, Brenda?
Thank you very much, and thank you for the report on this. I'm going to ask for one more piece of data, and I do apologise if it is already in here, but when you get to read data, it's sort of, you go a bit blind after a while, and the data I would like, I'm going to take a step back, is GP non-attendance, which remains stubbornly high, no matter how we try to deal with it through texts, alerts, etc. and so on. It stays high. So my question is about the self-referrals, and are we, I presume you are, collecting data on non-attenders to self-referrals, and I would like to see if that's becoming a problem, becoming a blockage, and how you. I know we can't sort of penalise people not attending GPs, even if we can't do a 3 strikes and you're out kind of thing. The GPs have to keep them on the books. But for self-referrals, is there anything the NHS can do if they are continually not attending?
Thank you. Very good point, and very timely as well. In terms of the general practice DNA work, did not attend and missed the appointment. We are kind of literally have just started last month a local initiative in terms of how can we support general practices in primary care to address that issue, working with people and communities. With regards to the self-referral pathways that are mentioned within the paper, I think that's something probably with the data we would need to sort of work with the providers to collect that and have that sort of impact on patients and our communities, also ensuring that there are no health inequalities issues that might be impacting on the rates of the DNA, and something that we can absolutely work towards. So that data is something that we can absolutely gather and probably share. Thank you.
And I do apologise. I think I should have declared in it. I am a member of the PPG of our local surgery.
Thank you very much for the declaration. Thank you, Brenda. Right, Zufri, if you want to, can I just see any more hands up? Obviously, if there are any supplementaries from the questions. Okay, in which case you can have the privilege of having the last question, if that's okay. Oh, I know. Okay, Zufri, you're next. You're now second from last. Okay, thank you.
Thank you. First of all, can I just congratulate the ICB on getting 29,000 responses? That's a phenomenal amount of numbers of people responding, and that is quite comprehensive survey. So it's really very good news that you're able to get the data so that we can look at it and look at it properly. What my concerns are and what my questions are, you talked about 500 more extra appointments. Who are these appointments with? Are they with the GPs, with PAs? Are they with nurse practitioners? Who are they actually with? Because lots of people need that reassurance that they've seen a GP and lots of issues, and then they end up bouncing out back into A&E and they clog up the A&E department. That was one of the questions. The other questions I have is, I've been speaking to some GPs recently over the last few months, and lots of new GPs who have just qualified are struggling to find jobs because there's no job availability out there at this moment in time for GPs because they're employing PAs and lots of other people. What is the workforce plan for making sure that GPs get jobs locally here in Leicestershire? The other questions I have is regarding to the actual report. 51% of the responses said that the times that they were offered appointments for were satisfactory. That means 45%, actually 49% find it difficult to actually get the appointment at a suitable time that works for them, or get, and 45% of people also said they found it difficult to get through to their GP surgery. And that means overall 13% of the needs of patients were not met. And if you take that with the population of Leicestershire, about 1 million people, that makes 130,000 people are roughly not getting what they need from their local GP surgery. And that means that out of our GP surgeries and out of our hubs that you offer and out of our services like the walk-ins also struggle, and the A&E department. So is there any sort of plan to try and improve the out-of-hours services for these 13% that can't actually get any service from their primary care? And a final question, you talked about the PCNs and the fact that they're doing well. How much of a variance is there between the PCNs, some of the really good ones, and some of the ones that are struggling to actually deal with the services they're providing?
I'll take the PCN question first, if that's okay. There is a variance across LLR, and this is some of the variance is absolutely warranted. It has to be, because of the in which they design their services, design their kind of, the delivery of the services, the makeup of their workforce has to be based on, and should be based on, the needs of their population, working in partnership with local authorities, VCSE, etc. So there's absolutely a warranted variation. When we talk about unwarranted variation, this is around the in which the access, for example, I used practice website earlier. Every single practice has got different websites, so if we were to access them, they will have the basic access points in terms of on their banner will be there in terms of booking appointment, cancelling appointment, a bit of a referral, self-help. But there is no consistency. So this is where in not having that consistency impacts on which would the people and our communities access those websites. I'm using that as an example, and that's the initiative that we're putting in place, recognizing that there is a unwarranted variation, and what can we do about it in terms of supporting practices and PCN to have that consistency, so that does not impact on our people and our communities. So there is a balance between warranted variation and unwarranted variation. I don't know whether if Sue wants to take the patient experience question. Sue?
Yes, thank you. Yeah, I mean, you're quite right, Zuffer, in terms of, there are two questions particularly relating to the appointments. So one is around the availability of appointments, and I think we do need to consider that part of that question might be the perceptions of people rather than the reality, because then when you cross-reference it with whether they were satisfied with the appointment being offered, that does go up to 62%, obviously not where we would want it to be. So I think those two questions do need to be taken and looked at as a whole, rather than with isolation, in isolation. And we also need to consider the date when this survey was actually done, which was between January and March, and that was at a time when a lot of the changes and improvements for general practice were actually being implemented. So it was taking almost a moment in time. Obviously, a huge amount of changes and improvements have been made since then, and that's why we're constantly reviewing and going back to patients to continually get their perceptions, and we will be redoing this survey again in January to actually look at the direction and how far we've come on things. But I do think we do need to consider the moment in time when the survey was undertaken.
I'll just pick up on the questions, I think, around the appointments, and particularly around the access and looking at GP general practice access and out of hours access. So in terms of the appointments and who are the appointments with, there's an array of clinicians that provide appointments. Predominantly, though, in LLR, the appointments are general practice GP appointments, and then you have got a smaller cluster of appointments that are delivered through HCAs for phlebotomy services, bleeding services, for example, clinical pharmacists who provide medication reviews, etc., for patients. And you've got obviously physiotherapists as well, and you have got AMP, advanced nurse practitioners, and nurse practitioners that will provide sometimes minor ailments and minor injury services from general practice. So there is an array of appointments. We do get a breakdown, a broad breakdown, but we don't get a detailed breakdown. One of the things we do know through the additional roles reimbursement scheme, we've got a breakdown of the workforce and the type of workforce that's in place from a primary care network perspective, through which things like PAs would be employed. And one of the things we know through that data is actually we don't have a lot of PAs employed through our general practices in LLR. I know there's a national focus around this, but locally, the focus always has been and will continue to be working with our general practitioners and GP practices around making sure that their workforce is reflective of the needs of their patients. So they are employing people who they need to support their patients in their practice. And I think that's really important. The other thing around the same day, we've got a programme of work at the moment that we have started this year to look at our same day access. We know we've got a huge amount of work to do. Same day access isn't just about same day access to general practice, it's about same day access across a number of services, and that includes urgent care services. So that piece of work has just started, and we've started to review to understand what the need around that is, and how do we better meet that need, looking at a much more integrated provision, not looking at provision at general practice, looking at it in out of hours, looking at it in urgent care centres. Actually, what is the need and how do we get those services working much more closer together? So that piece of work has started this year. We're looking at that huge transformation piece of work. So that's for 1.1 billion people across LLR that we've started that piece of work for. So it's almost like a 2-year programme. We're envisioning that 25-26 will be really about implementing those new models of care as well. And again, we will be coming back to yourselves in terms of those plans and engaging yourselves with those as well.
Thank you very much. And it's just building from what Yasmin just mentioned, is practices when we are looking at employing what would our patients' need be. So obviously it was quite different few years ago, but now you've got physiotherapists, and who do a really good job in support with all those conditions where actually it really supports with the whole general practice and that working collaboratively together. So your pharmacists, your social prescribers, your physiotherapists, they all form part of the team, and they can provide that clinical care where the patient needs it and what's best for the patient. In terms of obviously the GP workforce, which you sort of highlighted the question. So again, practices are appointing on basis on what their patient needs are, looking at what the population needs are and who best is placed to provide that sort of care. I think we are trying to also work, because I know when the provision came out around the ARRS staff, it was very, which areas would you be able to appoint within those ARRS teams. So I think we are now working more closely with our regional and national teams to see what flexibility is there within our ARRS funding, which is given to practices. So that's a work in progress which is going on. Thank you.
And Councillor Huck, in terms of the GPs looking for a job, I think from our workforce strategy perspective, depending on where they want to work, what sort of area they're looking to work. I'll share some contact details with you. If they can contact us directly, we can absolutely support, because part of our strategy, part of our development work that we would do with general practices, PCN and beyond, we can absolutely build that in, so if that's okay. Thank you.
So I think on general employment, we've had past papers, which I know we're going to be coming back to on employment take-up and retention within the service, which I know is obviously key interest to everyone. Ray, I think you've got the final question in that case.
Thank you very much. As a fully paid up member of the group commonly referred to as the elderly, I would like to make a plea over the question of access, because that group, and I speak as a representative of it, we don't all do IT well. We don't all do jargon well, like interface, pathways, and other words that have been used commonly here, and get thrown in. I'm a volunteer driver, and I go to all the hospitals, and I hear all these things being said to some of my elderly passengers all the time, and the amount of time I spend interpreting for them and explaining what this very nice nurse or doctor or whatever meant. I don't go to the GP practices often, but I suspect they get the similar thing there. It's about remembering that elderly people don't think as quickly, they don't understand as much. The world's going on at an incredibly fast pace, which they frequently struggle to follow, and what they need is time. More than anything else, they need time, and they need one-to-one and somebody to explain things jargon-free. And that, I know that's a challenge for the NHS, as it is for the local authorities, because we're dreadful at jargon. We absolutely absorb it. But I just would make a little plea, please. Remember, an elderly person, right, is not what you see in front of you. They were something before. Try to think of them in that sense, and don't talk about them as a project or a problem or an illness, because that's demeaning. And I've heard that said many times. So just think about the people, please.
Bessie. No. First off,
not happy.
We'll come as a supplementary, but the question was directed at our guests, so we'll ask them to come back. And then
I
if you want to
hope
come in as
so, because
supplementary,
I'm not
that's
happy with that
absolutely fine.
point.
Okay. Okay.
Treating all our people with respect, I think, is really important, regardless of everything. We've got to remember that. And I think absolutely we do go into jargon. I think, you know, we have to remind ourselves, and I have to remind myself, especially when I'm talking to communities out there whose first language isn't English as well. So that poses additional challenges in terms of that. So we need to ensure that, thank you for that reminder, and reminder that we've got to be mindful in terms of how we use our language, how we work with people, and treating people with dignity and respect across the board. So no, absolutely take that on board. Thank you.
Probably the key takeaway, and I'll come back to Bessie if she disagrees. But look, for most people, when they actually contact the health service, you know, often it's because you know, they're having to do so because they don't really want to, but they feel lousy or they feel ill. Their mindset and everything else is all over the place. Clarity on communication doesn't matter whether it's actually an old person or a young person, because to be frank, you know, I struggle with the TLAs and the jargon as much as anyone else. I think we all do, and I suspect probably within the health service, you know, you're prone to sometimes coming across stuff and thinking, I've heard this a million times now in the last 6 meetings. What on earth does that mean? But the clarity on communication, regardless, is important, because actually you're dealing with people who are often under stress, in distress, and to be frank, you know, the clarity of communication is key at those moments, because quite often people forget to ask the key questions. They forget to actually ask the supplementaries that otherwise they would have done, and you know, I suspect a lot of the follow-on, particularly on the GP services, a lot of follow-on appointments are as much about, you know, I didn't ask at this time, or I'm still worried, or I'm concerned because I didn't quite understand what was being said. So, you know, the greater clarity, the more significant the service. You're nodding away, and I suspect you probably understand it.
What we wanted to highlight is obviously that's why the patient experience is so important for us. So we need to get that patient experience into us and what we have done with our service, but obviously hear more from you to get that patient experience, because if we are not getting it, then we need to work harder on some specific areas. Thank you.
We've got a short running order, so Ray, if you want to come back, Bessie, did you want to come back at all? Are you happy now with the clarification? And then we have got a couple of points. Janet and also Karen want to come back as well. So Ray, if you want to quickly,
just want to make it clear, I'm not criticising. I just my own experience as a volunteer driver has informed me. I frequently have young elder people in the car, and we rehearse. I mean, I'm a complete stranger to them, but we rehearse what they're going to say when they have their appointment, and then we debrief on the journey back, you know, because that's what you do. But it's not a criticism.
Thank you very much. Janet, if you want to come in as well.
Yeah, just two very quick points following on from Councillor Payne, if I may. One is that as we move more and more to telephone consultations, this is very, very difficult for people who are hard of hearing, particularly if it's a poor reception on a mobile phone, or it's an accent that they can't, you know, a very strong accent, you know, somebody from Scotland or whatever. Sorry. And my second point is the complexity of the system. People don't know how to navigate the system. They don't understand it. And also, if people with a low level of health literacy, and all these people need to be considered in all the plans going forward. Thank you.
Absolutely. Karen.
Yeah, I just wanted to suggest, because some of the documents inside this agenda, it could do with an acronym sheet at the beginning to make it easier to read. Probably one for you. And
I was going to say, I appreciate, I think the city used to distribute the TLA and FLA and whatever, all the LAs. So you and I don't know whether we can actually adopt an acronym sheet just part of the agenda pack.
Yeah, something we can look into. Yeah.
Thank you very much. Okay, Betty, do you want to come back on the age thing?
Yes, I mean, I travel in and out on the bus, as you know, quite a lot, and I do talk to a lot of people of all ages, and some of the most switched on ones, they put me to shame at times. So I don't think it's an ageist thing at times. I think it's knowing your way around the system, knowing what's there, how to use it, who to speak to, etc. And I think it's common across all age groups. Perhaps it affects the elderly more, I don't know. But as I say, I do talk to quite a few because, as you know, I don't drive. I'm on the bus quite a lot, and it's like my surgery sitting on that bus. So let's not, put it down to one age. I think it straddles all age groups.
And I think it's also fair. I mean, I know GPs who sometimes even when their family are not well, have sometimes struggled with some of the communication. So I absolutely agree with you, Betty. I think it's just there we go. It's just as part of the system, everyone understands. Okay, look, thank you very much for that. It's a really, really good paper. We're looking forward to, you flagged many times that this is going to be a recurring issue, and I think we absolutely agree with you. Access to primary care, it's the front face of the health service for all of our residents. The better it is, the more support secondary care gets, and they can concentrate on what they do best. But primary care is absolutely important. I'm really, really keen to see how Pharmacy First operates. It's great to know about the fact that we had a great take up before, and I have to say it's a really impressive system. And a huge number of pharmacists I know are really, really, really keen to be able to demonstrate their clinical knowledge as well, and their part in the health service. So it's really, really good scheme to get underway. 100% take up. I'm looking forward to seeing that at the next meeting. But thank you very much for all four of you, including Sue, who's hovering above you, looking like the sort of the all-controlling individual. But thank you very much for joining us today, and we look forward to seeing you again soon. And thank you for the paper. Take care. Thank you. In that case, we'll have you back. Okay, thank you. Right, so we now move on to item 9, which is access to dental services for Leicester, Leicestershire and Rutland. So has everyone got nameplates? Who've got nameplates? Okay, Lewis, I can see your nameplate. So in which case, I will ask Lewis to introduce the team that we have in front of us as well, for particularly our new faces. So once you're settled, as I said, absolutely, we take the paper as read. Gives us more opportunity to, as you've just heard, more opportunity to discuss and ask questions. And but otherwise, if you want to take a little bit of time just to talk about any key points in the paper before we actually come to questions, that would be good. So over to you if you want to introduce everyone first, so explain their role, that would be excellent.
Hi again. Hi everyone. So yeah, thank you for inviting us today to the Health Scrutiny meeting. So my name is Lewis Parker, Commissioning Manager, and I cover both LLR and Northamptonshire. And we also cover a range of services, so dental, pharmacy, optom and GP. So I'm joined by Katrina.
Hello everyone, I'm Katrina Peterson. I'm Associate Medical Director Dental, representing the East Midlands. I work across the 5 ICBs.
Hi everyone, I'm Jenny Oliver. I'm a consultant in dental public health. I work for NHS England and I cover 3 ICBs, including NLR.
Thanks everyone. So yeah, obviously we're here today just to give an update on the dental access in LLR, and I know we previously gave a report back in March. So just to pick out the key points from the paper I submitted. So the level of service remains the same as of March, with 133 dental contracts across LLR. Included in the report, you should see the latest access figures, highlighting areas such as Blaby, Harbour and Oakley and Wixton as the areas with the best access, and areas such as Rutland and Melton and the city with the lowest, depending on which age group you might look at. Month per month, contracted delivery is generally higher in LLR than the Midlands average and the England average, which has gradually increased since the pandemic. With the number of unique patients, a unique patient being a patient only counting as one, standing at 92% of pre-pandemic levels currently. Since the last update in March, we have received no further contract terminations, I'm also pleased to say. So moving on to kind of our future plans to improve access in oral health. So as set out by the Dental Recovery Plan, which is nationally set, across LLR, we've increased the minimum UDA value to £28 per UDA. This saw 46 providers across LLR benefiting, which required a further investment of £494,000 from the ICB. Additionally, all contracts bar one were opted into the new patient premium scheme, whereby providers now receive an additional payment of between £15 and £50 when treating new patients. That's seen around 19,456 UDAs awarded in LLR since the 1st of April. We're also currently in the final planning stages of the dental recruitment incentive scheme, which may look to recruit up to 4 new dentists to LLR via a bonus payment of £20,000 over 3 years. A joint planning day took place on the 10th of May, with each East Midlands ICB in attendance to plan commissioning intentions over the next 2 to 3 years, underpinned by the newly drafted Oral Health Needs Assessment. As previously referenced, Rutland and Melton are areas highlighted for poor access, and we have a procurement set to begin in September for an additional 10,000 UDAs in Rutland, with Melton also set as a priority in our commissioning plans. Also prioritised was further work to reduce the general anaesthetic pathway for children and special needs adults, of which an additional 84 sessions for 24-25 were recently funded by the ICB. Oral cancer was also highlighted as a priority, which Jenny may touch on later on, as some work is already underway in collaboration with various stakeholders, including a council-led oral cancer campaign, again funded by the ICB. These plans are set to be formally submitted in September this year, underpinned by a quality framework and decision tree highlighted in the report. Work is also underway to utilise any underspend this year, non-recurrently, exploring offering 110% overperformance to well-performing providers, as well as exploring flexible commissioning, whereby providers may be able to use their existing contract in order to target specific groups and cohorts, for example, the elderly or children. This is due to be presented this month for governance approval in order to proceed to begin further improving dental access. I'll now open up to Katrina and Jenny and Salaxini if there's anything they did want to add at this point, and then we can answer any questions you might have. Thank you.
I don't have anything specific to add at the moment, but happy to answer questions later.
Apologies, I thought it was on once. Just a little bit more on what's happening around oral cancer at the moment. Oral cancer isn't something that the NHS can resolve alone, obviously, because prevention and treatment are both important. And the council, Leicester City Council, has a mouth cancer plan, which is looking at prevention, which is fabulous, and looking at reducing risk factors and increasing awareness. And that's supported by a multi-agency working group. From an NHS perspective, it's about getting people with the highest risk into dental practices, and through our work around the planning on the back of the Oral Health Needs Assessment, that will be about reducing inequalities in access and targeting those who need it most. So we should be able to do more opportunistic screening of people that come through dental practices. And there are various meetings and committees whereby we are working collaboratively across the system, and oral cancer comes up in those, and that's LLR dental meetings and Oral Health Promotion Partnership Board. We're also working with the leads for face and cancer in LLR and working with clinicians via the Managed Clinical Network and Local Professional Network.
I think just to add to that, we are trying to link in, making sure that it links in with our place plans and with our cancer prevention plans. So why those same risk factors are across various cancers, how do we actually build in together and focus on those areas? And again, working with GP practices through this one is to how can we increase the awareness, and then the referral, how does it actually go into the system? So making sure that it's all interlinked. So that's work in progress.
Okay, thank you very much. We've got various hands coming up. So I've got Trevor, I've got Mike, Ross. Okay, we'll take those in order at the first. I'm just going to ask one quick question as chairman's privilege. Sorry, Trevor. Can I just flag the 0 to 17 access? Children have, I mean, it's the only category, I guess, that has automatic access to NHS dentistry. 50% at the moment are accessing it. What information do you have about the other 50%? I ask that primarily because, you know, the great thing about dentistry in particular is that it's a preventative system as much as anything else. It's one of the few within the health service that we have that, you know, if you can pick up stuff early, you can actually cut down a huge amount of later necessity on treatment. You know, particularly for children, if they can actually retain and keep their teeth in good order up until they're 17 or 18, the chances are they probably will be good for life. And obviously that relieves a huge amount of pressure on the dentistry service in particular. So it really is obviously quite concerning to actually see only 50% access, because unless the other 50%, roughly 50%, are accessing private healthcare, then that means that we have half our child population who are not accessing dentistry at all during their youth, which doesn't bode well for later life. So just if you can fill me in on what's happening, what information do we have about the other 50% that are currently not showing up on those figures?
So Jenny may be able to give you some more details on the figures, but actually historically the NHS has only ever seen 50% of the population and provided NHS. So we know for children we'd rather be a lot higher than that. And some of the flexible commissioning initiatives are looking at providing more access specific for children. And also even more specific for looked after children, because we have identified those as being in greater need as well. But Jenny, do you have any figures?
It used to, you hear me okay? Yeah. It used to be more than 50% for children, so it's definitely dropped off since COVID. There's no doubt about that. The needs assessment does look at who is attending and who isn't, and that needs assessment will come to HOSC once it's been through the governance process in August in the NHS. And that will give you a bit more detail on what deprivation deciles people are coming from, what age bands are more, a greater proportion of children attending, where are they coming from geographically, that kind of thing. So you'll be able to drill down into the data a bit more there.
Yeah, if you can take off your microphone as well, sorry.
I think just picking on the point which you said, a lot of work needs to be done in those children at a younger age. There's a lot of prevention sort of work and things happening within some of the schemes which have been set up in terms of what would start in the summer versus autumn, and the prevention work which would be is happening within schools and within the summer camps in different areas, which the focus has been to get that, you know, the elements right, the prevention work, so that they don't have the tooth decay to then need a dentist, and that sort of prevention work. Thank you.
Okay, Trevor.
Thank you, Chairman. It's about the referral that you can make for oral cancer. I think you mentioned that the dentist can make a referral. And I was going to say, and can the GP also make a referral? And thank you, you've answered that, which is great. So then on the margins of our county, and I'm going to talk specifically, Chairman. I know it's not right, but I should talk generally, but there are a lot of practices on the margins which do go to other authorities, Northamptonshire, Nottinghamshire, Derbyshire, and the like, hospitals. Is it your intention, as you do make sure the referral system kicks in, that you flag up that it should be possible to go to a choice when that pathway referral is made?
Certainly the dental referral pathway does have a choice. It is the patient's choice. That sometimes it's a little bit complicated, because the referral pathway for dentists in LLR is one system, and over the board that's common for the East Midlands, but the West Midlands isn't actually very far away. Nuneaton, I think, is in the West Midlands, so they would have to step into a separate referral system just to get the referral in, but they can do that, and it's a patient choice.
General practice has always had patient choice, so that's for all the services which we do that. So thank you.
Great, thank you very much. We've got a few more people on the list. So next person after Trevor will be Mike, and then it's going to be Ross, and then I've got Betty and Zuffa. And Janet, do you want to come in after that? Okay, Mike.
Thank you, Chair. Yeah, I think you mentioned there was 133 contracts out there in the LLR. I'd like a little more context around that. how many practices in total are there in the LLR? How many are doing NHS contracts? So a little more context about that. I like your plans for the future, but are you confident of achieving those plans fully? Because a lot depends on other people in this process. And then particularly about contract handbacks. 14 have been handed back, terminations. Just wondering what the reasoning behind those terminations was. And I don't pretend to understand these contracts at all. Are they for a fixed period? Are they open-ended? The reason why they've been terminated? And those that have gone contracts, what's built within it about what they need to achieve against it? I changed dentists earlier this year. I am private, which is fortunate. I can afford it. And I went to another practice in Wigston. And the first thing they said to me, we're not doing NHS. But I think they've got a contract for NHS services. So who decides whether they take any more on or not? Is it themselves? What's within the contract, what they should be doing against that contract? A bit jumbled, but you get what I mean.
Can I come in on the terminations bit, as that's the one I've remembered, and then Lewis is going to do the bit about the number of contracts. So most contracts are terminated by choice of the provider, and we're finding now the most are terminating because they haven't got workforce who are prepared to work on the NHS. So they're moving into the private sector instead. If they haven't got a workforce, they won't meet their NHS targets. If they don't meet their NHS targets, they have their NHS contracts clawed back from them at the end of the year. So obviously that destabilises the business. If they're able to work privately and have a stable workforce who's prepared to do that, then it's a much more stable working environment for them. So there's been a big shift towards private work, which is why some of the incentives that have come in place, so the increasing the UDA value has come into place to try and stabilise the NHS contract and make it more attractive to the workforce. The workforce are obviously the one who have to meet the targets, and they're paid per target that they reach. So it's very much a treadmill, and it's been recognised for many years that it's underfunded and wasn't a great system in place, but we keep being promised a new contract, but it's going to take a lot to move to make it something that people are happy working with.
Thank you. So yeah, in terms of the number of contracts, so there are 133 dental contracts, and I think that equates to about, the majority of them are 133 practices with contracts. There are a few that have multiple contracts with one practice, but generally there are around 133 contracts. In terms of obviously the plans that we have set out, and I reference kind of the plans that we've put forward both this year and working collaboratively over the next 2 or 3 years, it all ultimately, as Katrina's reference, comes down to kind of funding, which is obviously a common challenge across the East Midlands. We obviously know what we'd like to do in terms of some of the non-recurrent pieces of work. So as Katrina said, we've delivered the patient premium scheme, increased the minimum UDA value. We're exploring flexible commissioning in the dental recruitment scheme, but also kind of looking at how we can further support practices as well. So I know it might be through different pieces of work, such as whether we can look to, it's called 110% over performance scheme, so we can fund providers potentially an extra 10% of what they're already contracted to do, which obviously will look to improve access. But again, that all comes down to kind of what funding we have available and whether that's possible.
Very much for that. Okay, next question we have from Ross.
Thank you, Chair. And I should preface as well, I don't think you're in the meeting at the start to say I do work as an NHS dentist, so I'll try not to grill you too hard. And I think the other thing that's not been mentioned in this report is the UDA system was tinkered with about a year ago, where they changed, for example, more endos, and you've got greater UDAs than before. I'm curious, what is the overall increase in funding to deliver this package? We've mentioned the £20,000 Golden Hellos, the £500,000 funding increase for the minimum UDA value to cover that. A, where's that money coming from? And B, is there extra funding on top of that to deliver more UDAs?
All the government initiatives that have been put in place and we've been asked or told to put in place have not had extra funding provided with them. There's no extra funding centrally. So it has come from the dental underspend. So the contracts that have been handed back have funded those initiatives. A number of the initiatives, although they improved the contract for the people working in it, they actually, because it was giving them extra UDAs, it meant they met their targets earlier. So actually it reduced access. So they were, give with one hand and take away with the other.
No, I was going to say, on one hand, dentists appreciate that because the greater they get paid for UDAs or the faster they do their UDAs, they can maybe take more annual leave. But obviously, it's not really helping patients overall, is it? Because you need that increase in funding. So that was my first question. I've just got a few more questions as well. We mentioned in terms of out of hours care. I think there was 5 contracts for out of hours care right now in LLR. Do we think that's sufficient? It doesn't actually say what the amount of activity that they're doing is. Are you happy with the provision of out of hours care that you've got right now?
I think out of hours across East Midlands is being looked at because it's actually underutilised by patients, and we provide 8 to 8 provision, and actually a lot of those out of hours services aren't used at all. So it probably is one of the many things on the list that we need to look at, re-evaluating that and see how it would work better. It also, you'll know, out of hours urgent care is very limited, and most of the patients don't need urgent care. They need general care or urgent care and then general care. And actually, that's the bit. So having a prescription isn't going to solve an immediate fat face, but it needs to be follow up, and the urgent care provision at the moment doesn't allow that to happen. So we need to work on that. They stem from pre-COVID, these contracts. They started, I think, just at the beginning of COVID, but the thought about them was pre-COVID, where we actually needed urgent care because we had the general care access, but it was where did people go out of hours? But obviously things have shifted post-COVID or during COVID, and we're now in a very different place in access and things.
I was curious as well, I think, about why there's such variation between the districts in terms of the UDA delivery rate. So if you look at Blaby, I'll try and get the page up if you've got it in front of you, page 33. So Blaby district, 98.3% of the UDAs delivered, whereas in Charnwood over the border, only 75.2%. Now I can understand differences maybe between the city and Rutland and places like that, but I would have presumed that Blaby and Charnwood were relatively similar. So do you have any thoughts as to why the delivery rate's so different?
I don't know the Leicester area, but so I'll take the Blaby and Charnwood, you would think would be similar. I would say it's how the practice manage their contract and their workforce. So some of them will have workforce because they're somewhere where somebody wants to work, and then others may not have the workforce to be able to deliver the contract because they run their practice differently.
Can I ask whether this is also to do with university, because the sort of 10% of the Charnwood population is actually university students, and I just wonder about access, etc. of dentistry through that.
So to register, well, you can't register with a dentist. So if you have university students, they tend to not move to where they're at university. So yeah, that would affect. They might drop into the urgent care because they can do that with wisdom teeth problems and things like that, but general care.
It doesn't mean the overall percentage of take up by that figure, I suspect. I don't know, Lewis, unless you know.
I was just going to add something separate to that. So obviously, yeah, you can see there is a difference between Blaby and Charnwood, but also you can see obviously there's a lot higher number of UDAs that Charnwood are contracted to perform, which actually, when you look at delivery per head, is higher than Blaby. So it does come down to, as Katrina said, kind of the workforce that is available to deliver that contract and kind of the balance of the business in terms of how much private work they might do in comparison to NHS.
And this is probably a question for you as well, Lewis. There's been 14 contract terminations since 2021. Would I be right in thinking most of those were probably in 2021 or just after COVID? I doubt there's been that many in the last 12, 18 months.
Yeah, absolutely right. The majority of them were during that time. And I think, as we've referenced before, it is mainly down to workforce and rising costs that have been associated in recent years as well. But yeah, touch wood, we haven't had any in quite some time, which is obviously positive.
I think from a personal perspective as well, when COVID happened, there were so many different changes that the dental community had to go through. And I think a lot of practices that were thinking about handing back their contract just before COVID just thought, you know what, this is too much for me. I think let's just nip it in the bud now and just stop it now. But whether that's right or wrong. My next question is about the community dental services, and it's more of a general comment about if anything can be done to improve communication between secondary care and primary care. I've got an example of a patient I referred. He had a lump under his tongue and it'd been there over the last few weeks. It's probably about the size of a 10 pp, so it's quite distressing for the patient. And I didn't think it was cancer, but I still referred it on the 2-week waiting list to the local hospital. And he was seen, and the consultant there wrote back to me and said, thankfully it's not cancer, but normally this would go under the normal maxillofacial referral route. And they said that those are all triaged within days, and if they think that it's worrying and needs a 2-week referral, they can then elevate it. So it was really helpful to get that communication back from the consultant to say, maybe in the future you could have improved here. And I don't think that happens that much. So I was wondering, A, is there scope for better communication or even better training between secondary care and primary care? I think I actually work in Nottinghamshire, it's not in Leicester, Leicestershire and Rutland, and I believe actually that probably training in Leicester, Leicestershire and Rutland is better than Nottingham, but I'm not aware of any training that my local NHS trust gives to primary care dentists.
So thank you for raising that. Obviously it needs looking into a bit more to understand it. Can you presumably aware of the LDN chair, Pavni Lakani, Nottinghamshire? If you raise it with her, and then she can maybe flag it to the oral surgery MCN, which is actually across the whole of the East Midlands as well, so it will catch any areas if the problem is the same. But yeah, anyway, people identifying training needs is really useful for us, because if it comes from the people who are working in the system, they're the ones who know what the needs is. So thank you for that.
It's in the report as well about community dental support, where practices GDPs are going to be given increased training to try and prevent referrals to the community service.
Yeah,
in the report.
That's child friendly.
Yes, yeah.
Child support practices, yeah, and it has it just focused on children, and community dentists, and there's a sort of shared care model that they work on. So this is slightly different, isn't it, with it being secondary care? But yeah, look at that.
My final question is more from the public health angle, is what progress has been made on fluoridation in Leicester, Leicestershire and Rutland? Just to kind of illustrate the impact that fluoridation can have. When I was at university about 5 years ago now, and with the report on fluoridation and comparing the fluoridated areas in the country to the non-fluoridated areas, there's something like a 45% reduction in GA admissions for children to remove teeth. So that's kind of major impact that it can have. And even in non-GA cases, I think it was a 20% reduction in general decay rate as well. So just curious as to where we're at with fluoridation in here.
The decision around fluoridation now sits with the Secretary of State, but there is lots of support in LNR for fluoridation, particularly from Leicester City. Where we're at the moment is that you may be aware there's been no new fluoridation schemes for many, many years. And the Northwest have submitted an application for expansion, and that's currently undergoing consultation. So that anyone who wants to respond can do so before the 31st of July. And that will really be a test case, we think, that if that goes through, and of course it's very much up in the air what the Secretary of State decides to do, even more so now that we have a new government. But when we see what happens with the Northwest, we'll have a better sense of what chance we have of success here. And yeah, at the moment there's lots of support, but the actual process is really, the process of agreement is really down to the Secretary of State. So tricky.
Can I ask in that case, who actually makes the decision in Leicester and Leicestershire to make that application?
It's not so much an application as a submission. They call it a submission.
Who is that?
There is no clear process.
It's down to the Secretary of State to make the decision. And I know that Nottinghamshire has made a submission recently, and they had a response that just kind of acknowledged the submission.
And who made the submission from
It was the
Nottinghamshire?
council.
It was from the
Council.
council. What, the
Yeah.
county council or the city council or both
I
combined?
believe it was both.
Effectively, it would be through a committee like this because this is the only joint committee we have.
Yes, but the submission isn't the beginning of a process per se. And I think it's about getting clarity from the new government about what their process will be.
Eventually, all eyes were going to swivel towards you. So do you want to briefly explain who you are and why you immediately rushed to the table?
Yeah, thank you, Chair. So Caroline Trevithick, I'm the Chief Exec for the LLR-ICB. So some of the local conversations, just to give you a bit of a reflection on that. So pre-PERDA, I was approached by Leicester City Public Health, keen to start the conversation, and I think that's probably where we are at the moment. We're starting the conversation between the different health authorities. The city, obviously, with the dental concerns in the city and access concerns in the city, are really keen to press this, but I think it's through the public health route. I think that's the route that we need to take it. More than happy, we're having conversations with public health colleagues across Leicester, Leicestershire and Rutland. We can take that back to see how we might be able to join up some of those conversations. I think we're probably just at different speeds in each of the three local authority areas. But I think if there's general support from this group, I think it'd be really helpful to take that back.
It may well be that we actually have a specific paper come so we can actually then give our minuted support. I have to say, given I know Ross has raised it before, but given the weight of evidence over a significant period of time, actually it's surprising really that there has been a pause on those areas that haven't already had fluoridation, because the evidence is pretty overwhelming, and the clinical harm is the evidence again is there that there isn't. Certainly to the extent that would warrant otherwise. We're here we go. Mike Sandy's just walked into the room. Perfect timing, Mike. We're just about to make a decision for you. I think it would be good to actually have a paper coming back to us at the very next meeting, and then maybe we can actually discuss it specifically, because it's a big issue in its own right. But if the timing's right, then maybe this is the right moment to actually lend support. We'll have a quick question, and then I'll come to you, Ramsey, if that's okay. So we'll have a quick interlude on this.
So just to highlight that it's actually going to our clinical exec as well in August to get that wider full clinical support across the system to make sure that we can feed that into the public health papers. Thank you. Just wanted to highlight that.
Okay, thank you very much. Well, I think there might be a couple of city and county HOSCs before maybe the next joint one, but regardless, I think there's a good opportunity to actually then sort of sink in with papers across each of those areas, and Ramsey maybe to Rutland as well, unless Rutland don't want anything added to that.
No. I was actually going to put forward a motion in September, but on advice from Mike, that we should actually be supportive of this. And the other point I was going to make is that I believe that there was an approval in the northeast, which covers Northumbria, Durham, and Teesside. So they are the most recent one that have adopted fluoridation.
It's currently out for consultation, yeah. So the Secretary of State has yet to decide. Oh, that's the northeast. Yeah, it's the northeast.
Pardon.
And I'm assuming with reservoirs being what they are, that actually, even if one county area has decided on fluoridation, actually the water source may actually supply more than one county. They're not so localized. So I suspect this is probably a much more regional decision rather than necessarily a local. So we probably do need to sink in with all the other water source areas. Okay. Okay, look, there we go. Well done, Ross. You got there eventually with a good question that was going to generate a little bit of debate. Is that have you got any other points that you want to raise?
Not at this stage, no.
Okay. Look, thank you very much for that, Ross. Let's go on to Betty. I think you're the next one. Are you going to spring on as another debating point, Betty? No, good.
No, it's really about numbers, which are quite worrying. That when we talked about 50% accessing in a dental service, that means 50% are not. And my worry is when you go to the dentist, you could pick up so many other issues. And I wonder what more can be done to actually encourage people to actually attend more frequently dental appointments. And I think I'm quite worried about children, how that filters down through families as well. So it really is asking what more can be done to encourage people to access dental services. Thank you.
So obviously we need to provide access for them to go, but there's a lot more to it than that, because actually some people choose not to go even if their access is available, and a lot of that is through anxiety or other reasons. A cost, I suppose, is another big reason. I think we need to have the access to the end, be able to encourage people or educate them to go. So it's sort of a chicken and egg situation. But we, as I said earlier, we recognise that some of the initiatives that we are hoping to be able to put in place with flexible commissioning would give children priority. So when we do, and then hopefully if the children go, then the parents might go as well. Can't guarantee it, but at least it's a start, isn't it?
Thank you very much. Lewis, do you want to come in on?
Yeah, I was just going to add, obviously, some of the plans that we've spoken about within the paper, a lot of them are geared around to improving that access. So like I referenced, being able to overperform, providers being able to overperform to 110% of the contract. Things like we're looking to rebase contracts who potentially aren't delivering. So the funding that they get, we can then reinvest that to practices that can. So that'll, again, look to improve that access. The patient premium scheme was also specifically designed to encourage practices to see new patients that haven't been seen in the last 2 years. So again, that goes back to being able to see those people who potentially haven't had a dentistry appointment for quite some time. So yeah, I mean, a lot of the work we are doing is to tackle that problem. So
I just come in on a final note. Along with the initiatives we're doing, we're also linking them to a quality framework. And part of the quality framework is to look at how frequently people attend the dentist. Because at the moment, we know that we're in a bit of a cycle of the same people are there. They want to go, not necessarily to because they need to go, but because they're anxious that they'll lose their dentist if they go less often. So we're trying to break that cycle as well.
I think just to highlight that obviously during COVID that went down, but looking at the figures from April 22 to now, the number of new patients accessing dentistry, both in children and adults, is gradually going up. So that is good to see.
Wait, was that supplementary on Betty's point?
Yes, it is about children.
Okay, if you want to come in on supplementary.
Thank you. It's just, I sound like my father. We're talking about people coming to the dentist. With children, they're a captive audience because they're in the schools. Can we not go back to something that used to be common, which is have visits to the schools again? Get where they are. School dental nurses, school visits. It used to work once upon a time, long time ago, but it was a very good way of getting in, to children, because some families will not bring their children to the dentist, no matter how hard you try. Sometimes you've got to flip it and go the other way.
And that could be one of the initiatives that we're looking at with flexible commissioning, that we actually send dentists into schools. We then would expect those dentists, though, because you can't do the treatment in schools, you can identify, so you still need them to go somewhere else. But it's also quite complicated going and doing school visits because of consent, and actually the parents who don't take their children to the dentist probably don't read the letters that come home with regards to consent.
I accept that. There's always going to be a hard to reach group. We all know that in any field. But on top of that group is a much easier to reach group who can be reached with relatively little extra effort. And I think we're missing that group. It's take like an onion, take them in layers. Let's take this layer next.
Yeah. As I said, flexible commissioning, there could be could work with that. The other thing we need to look at is the oral health needs assessment in more detail, because you'll have all heard the phrase, the worried well, they will put their children forward, so they already go, so they don't need another checkup. So we need to really identify the harder to reach groups and work with them.
So I think you bring up a very interesting point, and actually this was discussed at our ICB board development session where we had a whole program discussing around dental. And in fact, this is one of the things which came up is how do we actually do the visits back into schools, and some of the dentists were actually keen to do that. So, and our local authorities were very supportive of that. So they said we can work around the consent in different areas with you, because obviously consent is taken for vaccinations and different things. How do we bring it all together? So we're looking at it through one of the pieces of work which we can work with our local authorities.
I'm smiling because the old phrase, what goes around comes around, is suddenly coming into my mind. It's very nice to hear a bit of common sense is being talked about.
Mike, do you want to jump in at this point?
Yeah, just because it's getting into local authority territory. So we did look at this. Of course, the issue is dental capacity and the having the capacity for dentists to come out to schools. So we did think about it, but where we've got to is certainly within Leicestershire is supervised toothbrushing, because that doesn't require full dentist support. So if we could revisit that, we'd certainly be open to it, but it's like anything with dentistry, isn't it? There's not enough to go around.
Thank you very much. Right, we've got Mike. Do you want to you may as well just say it there. If you want to flip over Cash's, otherwise, from my past experience, I'll start calling you by the wrong name. But
not if you could just give me more work to do, I'll just retreat.
That's okay. We'll find something for you. Okay, look, we've got 3 more questions, I think, coming in. Unless anyone flags their arms, I'm going to take Zufa, followed by Janet, followed by Karen. Unless there's anyone else. Ramsey, you've already had one go. Oh, yeah, you're pushing me. You're absolutely pushing me. Okay, Ramsey, you're the 4th and final in that case. Right, let's go. Zufa, do you want to go?
Yeah. So dentistry and dental. The dental decay situation in Leicester has been bad for over 20 years almost, and it's never, ever improved in that time. Why has that you've never been able to change the situation in Leicester City, and the situation just goes from bad to worse? We have a child poverty situation in Leicester City of over 40%, and I've been visiting some of the schools recently, and some of the head teachers have told me point blank, they have children who come into school brushing their teeth without toothpaste because their families can't afford the toothpaste. I've visited several of the food banks in Leicester City over the last few months and donated some stuff. But when I've gone in there, there's never been any toothpaste, never been anything like that, or even toothbrushes there to help families to support and make a real difference. You have a system that is absolutely bankrupt almost, because dentists are doing more private work because they pay better, almost double the amount that the NHS does. And all you're doing is moving some money that you've underspent to try and change the system and try and increase the numbers. But you're never going to increase the numbers. All you're doing is redirecting money to get a less number of appointments, paying them more money. But actually, you need more money in the system to be able to encourage the GPs that are doing the private work to come back and do some of the NHS work to make sure they hit their UDA targets and able to do that. But what you're saying here isn't really giving me any confidence that the situation's going to improve and that we're going to change anything in the tooth decay pandemic in Leicester, which has gone on for far too many years and is not changing at all in the future.
I absolutely agree with you. Tackling tooth decay is not something that's easily managed. It sounds simple, but it isn't. And it's not just about getting people into dentists. It is sugar. It's how often and how much sugar people have. And that's not something the NHS can control by itself. It's the system. It's also about fluoride, and we've talked about water fluoridation, and that would help massively if we got that in, because that strengthens teeth against decay. And it's poverty, deprivation. We know that tooth decay is very strongly associated with deprivation. So where you find deprivation, you will find tooth decay. So I'm not at all saying we don't want to help support this. We absolutely do. That's what we're here for, and that's what we care about. But it is about the whole system working together and reducing the things that cause tooth decay, as well as treating the disease. And dentistry is part of that, but it's not the entire solution.
Right, yeah, thank you, Chair. So, yeah, just on that one, again, it's sort of where the paper was about access to NHS dentistry. I think once we get into that broader conversation about dental health, then I think local authorities, that's our job. I know I came in on spec, but I think it's quite useful. Maybe after the event, it would be worthwhile if we could, I'll have a word with Rob Howard, my counterpart in the city, because it's worthwhile then knowing in the three authorities what we are doing in public health around oral health promotion, which is everything about sugar, obesity, it is the supervised brushing, the work that we do around oral health promotion within the three upper tier authorities. So at least there's an overview, and whether that's something then collectively want to come back to JHOSC, or whether that's for the individual scrutiny committees to consider, it might be worthwhile, because there is a deal of work. I can't really speak on behalf of Rob, and it's not much of a succor, if you like, to the figures, but there is an element of certainly we used to talk about Leicester City having the worst oral dental health in children in the country. That's, I think, the city are now in the kind of third from the bottom relegation zone is some progress, but clearly not as much progress as we would like to see. So, but I'll pick up with Rob because it's probably unfair of me to speak on his behalf.
Okay, that's good. Thank you very much. Right. Okay. Yeah, sure.
I realised the issue about the fluoridisation because I was speaking on it maybe 10 or 12 years ago. But the broader issue is healthy diet. And the problem is when you get into that a population of the 40% who are living on poverty, they can only access the cheapest quality foods and those products that are not healthy for you. And actually, all when we do is when we fluoridise, you actually have obesity problems, you have other problems. We're far better trying to tackle a broader range of issues and try and help those people, because otherwise we'll end up adding things to the flour and everything else, because there's lots of other issues with that poverty that you'll actually have a risk for, and we're better off, rather than trying to have a fluoridisation program, maybe look at what we can do and target our resources into the areas that we need to do and actually invest some money and try and improve their future, because that future is for the rest of their lives.
So I suspect that's probably slightly out of scope of this committee. So I understand the point, but I think it's probably slightly out of scope of this paper and this committee. But so we probably we'll move on in that case, I suspect.
I was just going to quickly say that the point is well made that actually to address oral diseases, you do need a multi-layered strategy, from very upstream system-wide things right down to fluoride on teeth in a dental practice. And to successfully tackle decay, it needs that multi-layered approach.
Absolutely.
And I think it's just picking up on this point and around how does that fit in with the other conditions as well, so your other long-term conditions. So it's a broader prevention agenda that we need to focus on in the long term, because it has an impact on various things, not just the oral health, but various other elements. Thank you.
Absolutely. I think this applies to all health issues. It's education and support is so important. Okay, Janet, in that case, do you want to come in next?
Yes, thank you, Chair. I'm going to challenge you with respect, if I may. I'm the chair of Health Watch Rutland, and the situation in Rutland has been dire for a long, long while. The people that can afford it do go to their private dentists, but there's a lot of people who can't afford it or are entitled to free NHS care but can't access it. We've been monitoring this at Health Watch for quite a long time now. We were first promised the oral health needs assessment last autumn 2023, and told that all the plans for improvement will hinge on this document being published. We were then told it would be in the new year, then we were told it would be in March, then we were told it would be in June. Now you're telling us it will be in August. Can I categorically have a date for when this document is going to be published? I haven't finished, sorry. So that's my first point. My second point is we have been consistently told that all plans for improvement hinge on the oral health needs assessment. So how soon after the document is made public will these plans be instigated? And then also you're saying about 10,000 new UDAs being made available in Rutland. That now seems to be September. Could we have a confirmed date? provider and details of how you're going to communicate this to the Rutland public, and possibly how you're going to actually cope with the backlog, and make sure that those in the most need are going to get their care first in Rutland, because it has been dreadful for the Rutland population. Thank you. Oh, can I just say one more point also on the UDAs? I have to go to a private dentist because I can't get an NHS dentist appointment anywhere. I go to a private dentist who has a contract for an NHS contract for children. He told me that he can't see so many children this current year because in his last year they exceeded their target, so they're having to cut back on the number of children that they see. Is that right? Is that fair? Seems crazy to me. Yes, I've finished.
I can answer the bit about the needs assessment. So it has been written because I wrote it, so I can promise you it's been written, and it's going through the ICB governance process, and it's going to the committee in August. So it does exist, and it will be hopefully signed off in August, and then it will be made available. But just a word of caution on the needs assessment. A needs assessment is not the answer to all things. It is the beginning of a process, and it gives the foundational understanding of the oral health needs in an area. But really, it is always about building on that and growing that understanding. And I think to truly meet people's needs, particularly those with higher needs, it is about understanding what that population needs from a service and collaborating with them to design a service that's meaningful for them. And a piece of paper with some data on it can't do that. So it does give the commissioners that starting point, but this isn't something that one document can resolve. It's a process.
Yeah, I was just going to come in, obviously, Rutland. So we did unfortunately have a large termination in Rutland, which didn't help the access there. But we are planning to re-procure that, as mentioned, 10,000 UDAs going into Rutland, and yeah, confirmed timeline for September to begin that process. Just touching on, obviously, slightly on the oral health needs assessment as well. Although it hasn't been made public yet, a lot of the commissioning intentions that we have provided in the report are based on that as well. As I said, we had our planning day on the 10th of May, which did set out some of those intentions for the next 2 or 3 years. So we are already utilising that to improve access.
And then I think your final one about the UDAs and the overperformance last year. So the contract is linked to targets, which could be, let's say, 20,000 UDAs. You can, one UDA is one checkup. You can probably appreciate how difficult it is to manage that exactly in a year. There's always been a tolerance of under or over delivery, and with over delivery, if you over deliver, the UDAs that you do are taken off your next year's, because that's the whole reason the contract was put in place. One of them back in 2006 was to stop people doing more work, to put a limit on how much people could do, and that's never been changed. In previous years, and in some areas in the country last year, the tolerance for going over was increased to 110%. The ICBs in the East and West Midlands chose not to do that, because they chose to take the funding that was needed for that and put it towards paying off the bottom line on the other areas that they needed. So the practice was probably expecting to be able to do 10% over, and then were told in January that they couldn't. So they did what they did over, but that's been carried forward and has come off that. But it would only, well, I suppose it depends how big the contract is, but more than 2% over shouldn't make a huge amount of difference. So certainly at this point in the contract year on how many patients they can see this year. It is one of the things in the paper that we're actually asking the ICBs this year to support the 110% overspend, which will mean them paying extra for those, which is the problem, they actually having the money to pay the extra.
Can I ask, and Janet's probably going to follow that up, I mean, Lewis mentioned about a very large practice in Rutland withdrawing, and you talked about another practice, or Janet flagged another practice, obviously over-delivering or trying to over-deliver. Are those two linked? I mean, did children that otherwise would have got treatment through one divert to the other because that was then available?
They could have done, but it's not, not aware of it particularly.
Just for clarification, it was a large practice in Rutland that handed back its contract, but the private dentist I'm talking about is based in Melton Mowbray, which is the second deprived, the second lowest performer on your scales. So a lot of people from Rutland go to Melton or Stamford because they can't get a dentist. There is nobody taking on adult dentistry for the NHS in Rutland. You cannot get a dentist appointment there. Can I just ask, because Mike was whispering something in my ear, to go back to the Rutland 10,000 UDAs, when is that going to start to be delivered? How are you going to manage it, and how are you going to communicate it?
So it will go out to an expression of interest to the area of Rutland, and then any practice within a certain radius of the original terminating practice will be able to apply for that. We already do, in terms of our procurement process, have a provider that we already know will want that. It's set to begin in September, the procurement to start in September. The procurement can take it could take up to 3 months potentially. That's just how long the process takes. Due to the processes you have to follow in terms of market engagement, the scoring, going out to expression of interest. And then once that's done, we'll be looking to award that. So it is set for September to begin.
I can't impress on you how desperate people are in Rutland. It's bad, really bad. We're hearing about it all the time.
Thanks for Jan. Ray, you've got a very quick.
I just want to illuminate. I'm an incomer in Rutland. I moved in from Essex, my wife and I, 7 years ago. We still have our dentist in Wickford in Essex 7 years on because we can't find an adult dentist in Rutland. In fact, I'm going there next week. It may be a cunning plan by Rutlanders to keep the incomers out. And well, it's not working, but it could be. But there are other ways, that it could be done. It's just not damn well good enough.
Okay, I mean it's a good point. I mean, so obviously this committee looks after the city, which I think is probably about 360,000. The county area, which is about 710,000, and then Rutland, which I think is 37,000, 44,000. So but it's quite noticeable, I think, for people in Rutland when a service is dropped because of the size. It's quite a noticeable sort of omission or change, and as a result, having to drive out of the sort of Rutland area, which I appreciate people in Rutland are very loath to actually visit the rest of Leicestershire. But there you go. We'll charge you tax to actually come and visit us. But it is a notable thing, and I quite understand Ray and Janet's comments about sort of local services, because it's it is quite difficult as otherwise to and particularly if you can't travel because you have access to car, you're relying on public transport, etc. And we know from previous committees that obviously that's not ideal either. So.
Just quickly to say that these are all issues that are in the needs assessment, and the Health Watch reports were really helpful for that too. And I have reported some of the Health Watch information in the needs assessment. So there is an attempt there to triangulate.
I'm just totally dismayed that you're saying at least, well, nobody's going to be able to get a dental appointment in Rutland until next year at the earliest. Now, people are desperate with toothache now. People cannot afford the private fees. It shouldn't be in this day and age, which this delay, this perpetual delay that we're experiencing is just not good enough. you know, I just, yeah.
I just wanted to say it's obviously good to get that feedback, and obviously while we're working through the oral health needs assessment and the flexible commissioning work which we need to do, it's good to get the views so that we can sort of put those things, look into those, you know, what we're getting through the oral health needs assessment, which is being reflected, and we're working on the flexible commissioning. And one of the options in the paper, which Lewis did highlight, is looking at that 110% over performance. So that should hopefully increase the UDAs for the current practices to be able to provide that level of access. But we are looking into that one. Thank you.
Okay, thank you very much. Okay, we've got two. Sorry, is this a supplementary on this one? Okay, if you do a quick, we're running slightly behind schedule, so I'm going to be quite, as everyone appreciates. I'm very focused on the 2 hours for meetings. Okay. But so if you want to come with a quick,
I just wanted to say it probably manifests itself quite dramatically in Rutland because the way the area is. But this problem is probably across the city as well. And the reality is that there are probably thousands, probably tens of thousands of people across Leicestershire who are waiting for appointments and can't get them. And all the NHS dentists are actually doing more private work now, and they're not bothering with the NHS patients. So it's a big struggle, and it manifests itself really sort of vividly in Rutland because the problem is there and it's in a controlled area effectively. But it must be across the board, definitely.
Okay, thanks. Yeah, absolutely, point well heard. Brenda, is this supplementary on this one?
Just a very quick one, really. The amount of input that Janet's had in this meeting, I would like to voice my disappointment that Health Watch Leicestershire hasn't attended the meeting.
The gentleman that was sat over here at the earlier part, he was here from Health Watch Leicestershire. Yeah.
Therefore, I do apologise.
Apart from obviously we haven't had representation through the whole meeting, so it's partly a point well made. But anyway, thanks Brenda for taking that. Look, we've got two more questions. We'll come to those, Karen, and then followed by Ramsey. So I think you're the final two questions.
Thank you, Chair. I just wanted to come back to the NHS access, the 0 to 17s. Obviously, there's lots of complexities in that age group, and I just wondered whether we could have a breakdown of the different. 0 to 5 is a big thing, isn't it? If we could have more of a breakdown on that when we're looking to scrutinise the preventative work, I think that's important. So that was one. And I think Janet's right, the 133 practices with contracts is not enough when we look at Leicester, Leicestershire and Rutland. And if you live in Rutland, you know, you're looking at driving miles and miles. On the contract terminations, it's saying that people are being signposted on to different practices, which might not help in Rutland, or Melton might not help. But are these patients being followed up when they've been signposted so that they have found a dentist? So that's another one. I mean, this is personal experience. I rang my dentist in April to get a 6-month checkup, which would have been in June. Because I'd gone over that 6 month, I got well, it's on Friday in July. Bearing in mind, it's for me and my granddaughter. I've got parental responsibility for an ex-looked after child. So I got the appointment, and then last week I got a 68-page survey that I'd got to fill in yet again, not once but twice, for me and my granddaughter. Almost like I'd been struck off from that and was having to reapply, when it wasn't my fault. I was out of the 6-month checkup. You know, from May to July, that's when I got my appointment. So that put it over the 6 months. So is that common practice? Thank you.
It's not how practices manage their appointments, and the paperwork that they supply with them is all determined by them. The NHS doesn't expect people to have 6 monthly appointments anymore. Most people don't need 6 monthly appointments anymore. So I don't really understand what they were, why there was a problem. And that's a very long document that they asked you to complete. I would ask them why, because I mean, presumably it came electronically, did it, and you accessed on your phone or something? And
yes, it was electronically, and most of it was tick boxes.
Yeah,
but it still took quite some time to fill in.
I mean,
but
obviously,
yes, I definitely will ask when I go.
Every time you go to the dentist and they see you, they need to update your records to make sure that nothing's changed in your personal circumstances, health, etc. So they're under, just a general common sense point of view and for your own safety. But 68 pages sounds very long.
And just in terms of the breakdown, that's something we can take away and we can look into that and get back to you.
Thank you very much. I think last question in that case, Ramsey.
Okay, thank you. I think a lot of good work has actually gone into this paper, and so there are a lot of positives. But I think we need to be conscious of the fact that this has actually got to be, it's something that a lot of people in our communities are actually attaching a lot of importance to this update, because I go back to a presentation that was made to Health Scrutiny in Rutland in October 2022. And when that was boiled down, we basically said there isn't enough money in the contracts and we don't have enough dentists. So I would simply ask that we consider how this is communicated to our residents, and we all have an interest in that, because the facts are that not a lot has changed as I distill what has been said today in terms of the physical resources and the money. Thank you.
Yeah, we agree. We're very aware of the fact that we're coming up with plans, but somebody's got to pay for them. And the country as a whole money is in short supply, or seems to be for a lot of areas. We believe we need to still keep making the proposals and still fighting the cause for NHS dentistry, which is what we've done with our initiatives and things. And we're trying to find ways we can work around things. So we now have the option to rebase contracts without the provider having to give permission. But again, it's a process and it won't happen overnight. We've got to go through a 3-year consultation, basically. But we're trying to be more innovative, because if we then rebase and take those UDAs back, then we could then move them elsewhere. But yeah, we're in a very difficult situation as well.
I think we just need to obviously keep highlighting the issues we're having, and I think nationally they are recognizing that this is a major issue, so it's obviously been flagged up to the national teams and they are aware of it. But some of these changes do take time, and it doesn't create that you don't get a dent with the small things which you do, but actually over time, when you see over the few years, it will hopefully have an impact with all the changes which we're trying to do locally and nationally. They look into contracts and different things. Thank you.
Janet, is this a quick one?
Very quick, yeah. Just to point out that my understanding is there was an underspend on NHS dentistry by the ICS in the last financial year.
So yes, I think that was a national decision on what we got told regionally and what we can do in terms of that underspend. So it wasn't a local decision, but what was being told what needs to be done nationally through the finances and things. So it wasn't us making those local decisions, but what was being directed nationally to be allowed to make those decisions.
Thank you. Lewis, do you want to come in very briefly?
Yeah, I was just going to add to that point. It's absolutely about resources, and we are trying to, as Katrina said, use the resources we do have available. So we mentioned rebasing, but also flexible commissioning is a part of that, which shouldn't require those extra resources because it uses money from the existing contracts. So we are trying to work with what we've got as well.
That's good. Thank you very much for that. Karen, you just wanted us about updates.
I just wanted to get an answer for my third question about the terminated contracts and whether those being signposted had been followed up to see, because that might flag things up.
So patients of practices aren't registered with the practice, so it's hard to define who the patients of the practice are. And as the practice is terminated, they've signposted and then they've let those patients go. And the NHS doesn't have a database knowing who those patients are. So we haven't because we can't. Sorry.
Is an extraordinarily good point to make, but I also understand the commissioning system and the approach means why that information is sort of one step removed from the NHS. But okay, but it's I think it's worth bearing in mind, I think, for future. Look, I really appreciate there's a huge amount of questions that you can as you've experienced on this as an issue. It is an ongoing debate, and I appreciate the work that's been coming. There's been quite a few references to these assessments and various other bits of supporting information still being developed. We will be asking you back without a shadow of a doubt, because I suspect improvements hopefully will come, but there's always going to be a huge amount of pressure to move things faster. So thank you very, very much. Do you want to?
So just wanted to say thank you for having us here, because it's useful to get feedback, and obviously, when we're working through our plans, we need to get that feedback to be able to take it into our plans. So thank you very much.
That's really, really good to hear. Thank you very much as well. And also from our perspective, it's important that we're able to voice some of the things that sometimes are frustrations for individuals, but also feedback from residents. So, thank you very much for coming to listen to that, but also presenting the update where you are at the moment. And we look forward to seeing what happens next. Thank you very much. Thank you. Okay, we now move on to item 10, which is the item on learning disability and autism collaborative approach. We have. Hello, Mark. Good. So Mark Roberts, we have with us today. So Laura, you're with us as well. Is that right? Yes, good. So I have to be very, very careful, because as Ewan is well aware, we managed to call somebody by completely wrong name in one of our previous sessions a while ago, which much to their amusement, I think, hopefully. Anyway, so we're now able to you're going to take us through a little bit, just flag any points. We'll obviously take the paper as read. We will go on to then questions and debate. And I know the paper's asking for two things from us. One, to actually note the paper and the content, but also for this committee to support the work that's being done and the content of the paper as well, which I always nice to be asked to support something, because quite often we'd like to and we're not asked to. So thank you very much for doing so. Over to you, Mark and Laura, and if you want to just sort of tease us through into the paper, and then we can go straight into questions and any points.
So thank you very much, Chair, and thank you, the committee. I'm working on the basis that you're comfortable to spend as much time as is needed on this, rather than pressing it through. I'm very conscious that we're representing the work of a lot of different people and a very vulnerable group of service users as well. So I'm Mark Roberts. I'm the Associate Director at Leicestershire Partnership Trust. I've got a responsibility for learning disability and autism services. I also do some work in special educational needs and disabilities work, and I lead the Learning Disability and Autism Collaborative, and I'll explain a little bit more about what that is in a moment. And with me is Laura.
Thank you. I'm Laura Rodman. I'm the Project and Planning Lead for the Learning Disability and Autism Collaborative.
Thank you. Okay, so as a brief overview, as it describes in the paper, the Learning Disability and Autism Collaborative was formed in October 22, so we're coming up to our second birthday. The group is formed through a specific delegation of responsibilities from the Integrated Care Board to Leicestershire Partnership Trust to lead the development and improvement of the services. So in that collaboration, on a daily basis, we're working with people from all of the health provider organisations locally, including primary care. We're also working with all three local authorities, officers from each of the local authorities. And we are commissioning improving and delivering services through that group. That's enabled us to bring a really broad range of skills and perspectives together over the last couple of years, and to be fair, to take the performance of our local Leicestershire, Rutland systems for people with a learning disability and autism from the bottom of the pecking order nationally to, as you can see in the data that we won't labour, but to a much better position. We've still got a lot of work to do, and in a moment I'll hand over to Laura, who'll just give you a snapshot of some of that. The particular strengths, I think, come from, as a model, they come from the practice, the diversity of the practice in leadership, I think. They also come from a very inclusive model. So on any particular week or month, there'll be not just a group of, say, 10 or 20 leaders and managers involved, but a group of perhaps 150 people actively involved in leading improvements of one form or another. And that group ranges from people with lived experience all the way through to the most senior executives in the organisations locally. There's a good engagement in this. We've got good project and planning support, and we drive communication very actively as a social model. I would say that a collaboration doesn't really exist unless you've got really good communication and people believe they are in a collaborative. So we're increasingly driven by an equity agenda. It's a requirement for our collaboratives and partnerships in the integrated care system, but the element of this is very live and vivid in our work. Performance is strong. It's in the paper against the key performance indicators that were measured from NHS England with, but we are increasingly looking to expand our reach and our indicators to pick up other areas of work, and particularly more involvement with our colleagues at University Hospitals in Leicester, and more involvement around the earlier, more social impacts on health, which have been touched on in this meeting already, whether that might be employment or support for carers as well. There is a live autism agenda, which is co-created with the learning disability and autism learning disability agenda, but they are separate, but benefit from each other as well. So over to Laura, just give you a sense of what we're doing next, and then I'll just come back with a number of requests that we've got for you, if I may.
Thanks, Mark. Yeah, I'd just like to draw your attention within the paper to our plans and priority areas for the current year. As Mark mentioned, they're broadly focused on a number of areas. So really looking at providing early help and intervention with a particular focus on earlier help for autistic individuals. That's really linked to the work we're doing to create stronger community care placements. We're looking at improved quality of care, which will then mean, hopefully, that fewer people will then need to be admitted into hospital due to placement breakdowns. As Mark mentioned, we're continuing to look at how we can reduce the health inequalities that are faced by people with a learning disability and autistic people. We've got a really active project group working through that. Better access, we know there are waiting time issues that we're working hard, and it's about sort of how we can support people to wait well. And then, as we mentioned, it's about that increasing strategic alignment across health and social care. So we're looking at improved employment opportunities, daytime vocational support, really trying to align our plans across the different organisations, and also having more of a CYP and SEND focus as well, so we can really sort of capture all of those elements. And it's, as I mentioned, it's looking at having more people in employment, better access to respite care. So it really all works together to sort of implement our vision that people with a learning disability and autistic people can have meaningful activities in the community, can be with the people they want to be with and live the lives that they would like to lead.
Thank you. So there are a couple of requests, and I know this is quite bold to come to an overview scrutiny committee and ask you for something. But in the paper at point 18, there are we don't go to these days. We don't go to any committee or group in the organisations locally without asking for something. And I would really appeal to you to influence these particular quite focused elements. Learning from the lives and deaths of people with a learning disability, and in the last year, autistic people, is a really powerful programme of work that we lead on, and we have a through that learning and through national data, we have 10 specific actions which are at Appendix 4. And they've been widely communicated, but at every opportunity, if we were thinking about any pathway, any other area of health or care locally, these are the things that people need to do to try to reduce the untimely and early and avoidable deaths of people with a learning disability. We are always looking to drive forward our agenda in areas that would be known in our work as non-specialist services. So the areas that aren't always thinking about learning disabilities are the areas that can now have the greatest impact, we believe, for people locally, if they're thinking about as they think about making adjustments to make their services more accessible. And part of one of those asks is the reasonable adjustment digital flag. So this is a statutory information notice that's been placed on all health and care organisations nationally, and it's a flag within computer systems which identifies somebody's needs and, more importantly, identifies what adaptations that person needs to be able to have equitable access and improved outcomes. So that's something which is being rolled out in the coming months, so that'll be very important. Also, Oliver McGowan training, which is specifically a national programme, and I'd encourage anybody that's minded to do so to access that. It's available online and gives very good detail on really setting higher aspirations, I think, for people with autistic people and people with a learning disability indirectly, and really to embed. My appeal would be for any action that you can take to embed the requirements of this particularly vulnerable group within all other pathways and processes. Thank you. Very open to questions.
No, absolutely. Thank you very much, Mark. Thank you very much, Laura. Can I actually start? So the Oliver McGowan training that you mentioned, thank you for flagging that. I wonder whether Ewan, you can actually send a link round to, you mentioned that it was available online, and then hopefully we can sort of click through and actually look at that, because it clearly is important, and I think for the committee probably would be useful to understand what that covers. So thank you very much for that. Okay, Zufa, do you want to go first? All right, can we have hands up for questions? Dan? Any other questions at the moment, Ray? Okay, so we'll start with Zufa, then we'll go for Dan, and then Ray. Okay, thank you.
First of all, can I say congratulations on setting this up, because there is a massive, massive need out there. One of the biggest things over the last few weeks, talking to people, lots of mums in particular were worried about their children who are autistic, who have grown up over the age of 18, having to look after them, the care. There just seems to be a lack of funding from councils now for the services that were provided previously, and those families are really struggling. And one of the first things I'm planning to do in the next couple of weeks is set up a group just to talk to these parents and talk to these families, because there is massive, massive concerns with them, because they are worried about their future, what's happening, how they can deal with their child who's no longer a child, is a young adult, and what the services are out there. But there is not a lot of places for them to go, and there is a real struggle. So I'm really happy that you're bringing this forward. It's something that I'm really passionate about. I remember the LD health checks, and that was one of the things I championed while I was on the clinical commissioning group. There was only 3 practices in the whole of Leicestershire that actually did 100% of their learning disability checks. One was in Bagworth, one was on Narborough Road, and one was in Syston, and I went to visit all 3 of them. And one of the biggest things that was common to all 3 of them, they had a passionate person who was receptionist, who was out actually chasing down to make sure they saw every single person with learning disabilities and were making sure that their health checks were done. There were other practices that had 0% coverage, and always worried me that you know, some patients, some of these people were slipping through the net and they weren't actually being caught and weren't never being checked at all. So it's really good to see that there's a targeting response of actually trying to make sure you get to these people and it actually works. But I'm looking forward to working with whoever I can to try and highlight this issue, because it is a major problem, and we know that the councils are struggling financially and these services are being cut, and there's an unintended consequence, and that consequence hits these most vulnerable people. I do know Leicester Hospitals employed 5 people last year with special needs, and they're working away in their organisations. We need to encourage more organisations to do more, but there is a challenge here. You know, Marks and Spencer's in Leicester City Centre is now closing. There's a couple of people who with special needs who work in that store, and the families connected with them have contacted me and said, look, is there any other locations that we can get our children into to give them a value, because they love the fact of being able to do something and contribute to society, but they struggle because they don't have the wherewithal to catch the numbers of buses to get to work and the ability to deal with people on the front line, necessarily dealing with so many different people. So is there anything support that you're going to be able to do on that front as well? Thank you.
Thank you very much, and thank you for your support for it. There's a few different elements I just wanted to pick up. So one of our, as I describe them these days, lived experience partners. So somebody, a parent with lived experience is very active in Leicester City, particularly in the Somali community, and we are working with him this year to expand the reach of that type of work into other community leaders across Leicester, Leicestershire and Rutland, really inspiring similar work elsewhere. We really welcome your support for that work, and that particularly that individual who we're pairing up with our health equity lead to really drive some of that work forward. The particular area of interest there is over 18s who are autistic, interestingly. The annual health checks with the range, you'd like to, I'm sure you'd be glad to know that the range is quite a lot narrower now, so there's more people doing more annual health checks. We've had specific focus as well on the people that haven't had an annual health check for the last 2 years, and so we've got a specific project working on that particular group. Annual health checks are inherently a choice, and we need to respect that choice, but equally we need to bring the choice in front of people and make it easy for them to access. So we're working to increase that. We're not in any way resting on our laurels on that. It has improved massively, but it's there's more work to be done. Employment, we work on particularly, we had a health equity event in February where we had partners from across the system brought together to specifically look at this topic area. A key thread within that work amongst transport and other areas maybe of interest to this group was employment. And we worked closely with the Leicester City, particularly the Leicester City employment team who are supporting people into employment. And we work quite closely with our programme for lived experience partners as well with that. So if somebody comes to the collaborative and they're interested and they've got energy to contribute, they will be absorbed into our work. And the answer is never no. It will be maybe not that role at this point, maybe this role is more appropriate at this point for you as you would develop your skills. And if there's work opportunities for them, then we will work with the local authority as well to find those. But it's a live challenge, and we've set ourselves some expectations. One of the challenges for us is actually measuring progress. So employment for people with a learning disability is measured broadly once a year. It's quite difficult for us to make it a live topic area where we can see the impact of our work. So that's a challenge for us. I don't know if Laura wanted to add anything to that.
Yeah, thank you. I was just interested in the group that you mentioned that you're going to be talking to around kind of parents and families, because an area of work that it's very early stages, but we are looking at developing an autism plan across the whole of LLR. It will have an LLR focus, but will have specific place elements as well, reflecting the different local authority areas. But what we're wanting to do for that plan is really speak to autistic people and their families. We have a list of priorities we want to take forward. We want to talk to them about what matters to them. So we'd be really interested to link in around that group and then come and talk to that group and those individuals and really get a sense of what are their priorities, and then that will shape our plan going forward.
Okay, I think we've got Dan next, followed by Ray. Any other questions coming up? If there are any supplementaries up, and Ramsey, yes. So any supplementaries, I'll obviously take those as well. Dan.
Right, thank you, Mr. Chairman. I'm wholeheartedly supportive of this. Some years ago now, probably 10, 12 years ago, I used to teach children judo with disabilities. And it was immensely successful to them to see the achievements, how they could probably throw somebody if they moved in a certain way, and the excitement was amazing. And it certainly did a lot of good for me. I felt really it was fantastic, instead of teaching athletes, you know, going back to the very beginning. And I think it is important that we embrace children with learning difficulties into the community in any way we can, because they're there, and we need to be able to take note of it and see how we can assist these young people, because they're no different to us. Their brains probably wired a little bit different to us, but we may make that claim about lots of colleagues and other people we know in a jocular way, but theirs is a realistic lifestyle for them. And I think we've got to be really mindful and do everything we can and support you as much as we can. And as an authority, Mr. Chairman, I'm not sure how we could actually support more than a verbal, but if we could, I would be very keen to try and see something happen, because it's so easy to look the other way. And what I found, and people said to me, is it embarrassing teaching children? And I used to smile and say, well, no, you're embarrassed, but I'm not, and they're not. So we have a great time together. So it's just trying to break down barriers and say, you know, so totally 100% behind you. I wish you luck, and if there's anything I can do to help, I'd be happy. And I hope we as an organisation can probably mouth this or be supportive in this in some way, because these are young people, and God willing, they've got a future. So we've got to try and do everything we can to support. Thank you, Mr. Chairman. Thank you.
I could just come back on that. As you might imagine, I've always got an ask. I've probably got another one now, which is maybe to dig into it a little bit. I think the committee may be aware that Leicestershire, Rutland is currently one of 9 areas in the country that's focused on as a partner in the special educational needs and disabilities and alternative provision change partnership program, and the focus of that work, as it is in many of these areas of work, is really fundamentally it's about inclusion in mainstream environments and making normally available services normally available to everybody. So that's something that we do really try to encourage and support through our collaboration across those different teams. That embarrassment question makes me think of reasonable adjustments, and whilst we call them reasonable adjustments and make it sound almost difficult to achieve, what we have told repeatedly by people as specialists in this area is it's very simple changes that are needed, and we don't need to be overcomplicating it. We just need to be responding, and so if I had an ask, really, I think it would be it's a genuine ask, which is maybe lost a little bit in the number of bullet points that I've put in under number 18. It's that when people come in front of you here on any topic area, on any theme in health and care, it would be to ask them about what part of their agenda is addressing the needs of people with a learning disability and autistic people. And think about the leader top 10 to look to see, well, is that what you're doing? Because we know that despite all of this work, that people with a learning disability have a life expectancy of 20 years, less than we would expect, really. So there's plenty of work still to do.
Thank you very much. You just touched on something that actually Karen would like to ask a quick supplementary on.
Thank you, Chair. I just wanted to ask about social prescribing as well, because it's not just about employment, as Dan has said, with the judo groups. I mean, we've got a social inclusion group in Asmonsor that's about 15, 20 people. who have autism and learning difficulties. And they've helped with breakfast clubs, they've helped in the cafe, with sports. It's nice to walk down the road and somebody said, "Hi, Jake," you know, just like you're a normal everyday person, and you're included in that community. So please don't forget the social prescribing, because I think it weaves them into the community as well. So, and if you want some contacts for the social inclusion group, I'm happy to do that. Thanks.
Yeah, that would be great. Thank you. If we could have those contact details, that'd be brilliant. Just touching on social prescribing, I'm sure many of you are aware of the Joy app, which is a really it's a new development which allows you to search for groups and different support organisations within your area. So we can share the details of that. But it's not just learning disability and autism focused, but it does have that wider social prescribing element as well to it.
Very much. Next question, I think, comes from Ray.
Well, I don't want to alarm you, but I spent the last 20 years of my professional life working with children and young adults on SEND and particularly the autistic spectrum. So you're pushing at an open door as far as I'm concerned, and I wish you all the best. Just want to throw out a few extra points. In my experience, early diagnosis is absolutely vital. And I mean under 5 if possible. Got to remind people it's only in the last 30 or 40 years that this condition has even been recognised. And now I'd say it's only in the last 10 years that it's commonly recognised, that people don't ask what's that anymore when you're talking about it. There are thousands, hundreds of thousands of undiagnosed adults in our society. If you want to find them, look in the armed forces, the police, the fire service, local government, and you will find they have found little niches for themselves, but they are the people on what we'll call the softer end of the spectrum, the ones who can ape and connect. Interestingly enough, when I first started practicing, we thought it was only for males that had the condition. We now realise that actually it's for both genders, and once again it's the females have shown the way because they were able to hide it, mask it, ape behaviour, showing once again that we males are just one step away from extinction really, because we can't adapt to anything. But they did themselves an immense disservice because they did too good a job of camouflaging their condition, and so they were unrecognised. Now I think we've lifted off that and we are recognising. I'm going to make two particular points. Crucially, I believe one-to-one mentoring is a very vital way forward, particularly with the ones you pick up late, with the 14 pluses in that crucial teenage area, 14 to 20, where they've been missed in the school, or the school hasn't had anybody of any expertise, and sadly that's most schools, who can work with them. One-to-one mentoring, even if it's only 1 or 2 days a week or that, to get them out, to get them moving, to get them feeling that they have a place, because these people are desperately looking for a place and need someone to provide them with a route map in how to do it. And the hardest group of all, of which I know we have a significant number in Rutland, are those in the villages, in the small rural, I see nods. I've got a couple that I'm helping unofficially. They are almost lost. They are disappeared into the undergrowth out there, and there must be hundreds of them in Leicestershire, as in Rutland. They have the advantage that because it's small communities, they are accepted. You know, I'm not being facetious when I say we have the tradition of the village idiot in this country. You know, some of us get elected, but they, you know, in the villages, it's okay. He's a bit rural. The old expression used to be normal for Norfolk. You know, no, don't worry about it. He's okay. But of course, that doesn't help them confront their situation. That doesn't help them grow, move forward, and make a further journey. And I think it's those people who are most at risk of all in that spectrum, is those people out there when in their early 20s, they begin to realise that this is all there is. This is my life. It's not going to change. They're the ones that get found several months later, having been dead for ages, because no one has sort of noticed them. They slide away, you know. and there's a lot of them out there all over the country. So it's a big job. I've been every confidence that it won't happen or finish in my lifetime, but good luck to you. You have all my support, and I'm sure this whole committee will give you its support.
Thank you very much. I mean, it's really appreciated, and we'll definitely pass on the support we felt today from the whole group back to the team. Early diagnosis, you will know, is a major concern for this health and care system. There's 7,000 or more children waiting today for a neurodevelopmental assessment across this area, and many besides that perhaps aren't being presented yet because of that wait. Tremendous amount of work in the team that I'm involved with in my operational role in Leicestershire Partnership Trust to resolve that, and money trying to be diverted to address it. But unless we create a more accepting environments in schools and in the community, we will not resolve that issue with money alone, unless we find a lot of money, and I'm not sure that would be entirely the right route. And absolutely, we recognise masking in ladies and young ladies, and still there isn't parity between the numbers of diagnosed. So there's a whole area of inequality which is right in front of us when we're looking for the complex. And we are increasingly working in an environment which is all about reducing inequality, but we are focusing on intersectionality, the overlaps of that inequality. And so we're interested in spotting each of these different areas, and rurality, and the particular needs of that will be an area that we would need to look at more. I don't think we've looked at that as much as we might yet. And we have a number of different programs that are associated around this, that are about mentoring, like key workers, that from Bernardo's that we contract to for young people in education. I couldn't speak for the education sector in its entirety, but there are particular steps that people are taking, and the PINS program, which is about inclusion of neurodiverse children and young people in schools. Its purpose is to make the environment more accepting and more flexible, rather than pressing into high needs funds and the likes, which local authorities, from what I understand, are genuinely concerned that could bankrupt them. That's good.
Have a supplementary, sir? Just to say, what is very heartening is that you're here in front of this committee, and that we're having this conversation at all, which we would not have had only a few years ago. And many of the terms that are being used and people in this room understand probably wouldn't have been understood 10, 15 years ago. So we are making progress, but like all people in this field, I wish it was quicker, but good luck to you.
Thank you very much. Okay, I think we've got a final question coming up from Ramsey. Can't see any, no other hand. So Ramsey, go for it.
Okay, thank you, Chair. I'm entirely supportive of everything that you're doing, and I hope that we will be able to at least make some recommendations as a committee, which I think is all we can properly do. My wife was head of SEND in a secondary school, but I don't have personal knowledge. I wonder if I could ask you just to say a little bit about the screening inequities that exist and the efforts that should be made to improve uptake. Which is point 7 on one of your slides. Thank you.
Absolutely. I'm hoping Laura might have some data to bail me out on this, but I haven't got numbers in front of me. But we see both very good practice and the need for support in routine screening services across the health sector. We had a particularly good presentation which from a Macmillan nurse recently from University Hospitals of Leicester, describing the improving access to screening services. We've just launched videos which have been contributed to by our clinical lead, GP, and our primary care liaison nursing team, which is a small group of specialist learning disability nurses that help primary care practices to respond really well. And those videos are all about accessing cervical screening and improving myth busting for people with a learning disability. So they're formatted in a particular way, which is really accessible, and we're promoting those through all routes at the moment. We're interested and always willing to carry on building that type of agenda and those types of products, but we're also trying to lever some support regionally. So there's very little point in us creating that type of product and then Northampton doing it and then another area and another area doing it. So if different teams can do that, we're more than willing to share what we've got and equally use other people's. I haven't got data in front of me about the uptake, but we could bring that back or send that in, but unless Laura's got something.
Yeah, just in relation to cervical screenings, as we mentioned, we've prepared the videos for that, and that is really on the back of data we've got, which shows that currently less than a third of eligible women with a learning disability attend for a cervical smear, which is compared to around 73% of women without a learning disability. So there is a significant discrepancy there. That, just to say, the 73% is based on the it's 2019 data, but that's the most current data that we are working to. And as Mark mentioned, it's very much around myth busting, and particularly also for families as well, because often there's a misconception that you have to be sexually active to attend for cervical. So it's all those kind of myth busting approaches that we're taking. But yeah, there is a discrepancy, and that's what we're working to address.
Thank you.
Thank you very much, Ramsey. And look, thank you very much to Mark and also to Laura for joining us today. Thank you very much also for what is actually, and Karen mentioned to me before the meeting actually just how clear this paper was, which I think is probably a testament to the clarity of thinking from your part, but also knowing your audience, I think, as well, because actually, as has been mentioned earlier on, the NHS in particular is sometimes over-acronizes papers, but so thank you very much for being very clear and succinct, particularly about your ask. I'm going to ask the committee in a couple of seconds to show their support for the points that you raise. I think it's also important from what you actually said about thinking about this beyond just today to actually address these points in all the papers that come to us, both here but also in our respective local authorities. So hopefully we'll all do that, and we'll actually talk to colleagues to make sure that that's actually done as well. And obviously, we always look forward to having you back to talk about updates and anything else that we can actually support. So Karen, I wonder if you can actually second me. I'm going to propose that we actually support the recommendations and particularly show our support. Yes.
Come in. We do, with all the papers, have the equality paper with it. Whether this could be put forward on that.
It's very good. So we'd have to ask our respective HOSCs, I suspect, and our authority to do so. But I mean, maybe we can formally, as part of this, as an additional recommendation, ask that actually feeds down to our respective HOSC chairs, most of which are, I'm sure, within this room, and then we can actually ask that that's done. Is that okay, Ewan? Okay, Ewan understands, so that's good. So thank you for that additional comment. That's great. Karen, are you happy to second?
And I'm happy to second that recommendation.
Okay, can I ask for all of those in support? And that's everyone. Thank you very much, and thank you very much to the two of you as well. And thank you to colleagues for joining today. I've just realised the heating is on full blast in this room. All the radiators are on full blast. It's 20 degrees centigrade outside. It is the middle of July. It is allegedly summer, but here at County Hall, it's still the middle of winter. So thank you for everyone to stay awake, despite the fact that heating's on full blast. Thank you, and we'll see you all next time. Take care. Bye-bye.